Sim, e. 1, 2, 1, 2, 1, 2, 3, 4. Sim, e. Sim, e. 1, 2, 3, 4. Sim, e.
Good morning, everybody. So, welcome back. I hope you enjoyed yesterday as much as I did. I thought the program was really good. I enjoyed the lectures a lot, but I also got a lot of feedback from many of you that you enjoyed the speakers. Personally, I was very much impressed with the presentation by Ilse on the maternal vaccine program by GSK. I think this was an historical lecture that I will never forget. But I also heard a lot of feedback on the other presentations and the interest that you have, that you've been interacting with the speakers. I heard several people say during the dinner yesterday that it's so much fun to see industry interacting. We don't know which company is which, and they actually seem to talk together. So this is also very encouraging for the academic part to see that there is so much interaction between industrial partners. So let's keep on doing that. It's the last day of the program. I think we still have an interesting last bit that will now be chaired by Ron Dagan, good friend of mine from Beersheva University in Israel, and Eugenio Baraldi, also a good friend of mine who was brave enough to trust his daughter to come to Utrecht for an internship from the Resvinet Foundation and Padova University in Italy, who will chair the first session on secondary effects of RSV intervention. So Eugenio and Ron, can I invite you to take over from here?
Well, thank you, Luis. Good morning to everybody. My name is Eugenio Baraldi, and I will chair this session with Professor Ron Dagan. The title of this session is Secondary Effects of RSV Intervention. And this is a very hot topic because, as you know, we are approaching a new era for RSV. So we needed to understand a lot of things about this. The agenda is very rich. We will start with viral interference, then bacterial pneumonia, then a very old topic, long-term RSV outcome, asthma and wheezing, and then the impact of RSV intervention on hospital burden and health systems. So I am very pleased to call to the podium Luis Bont, and let me congratulate to Luis and the Resvinet team for the huge success of this meeting. Please, Professor Bont.
Thanks. So here I'm back again, 5 minutes after I just left the stage. Now as a speaker, now I'm much more nervous, I can promise you that. Dan Weinberger, a fantastic public health epidemiologist, told me viral interference does not exist. I just reminded him that he told me that because I sense that I'm nervous to talk about this topic. And then he said, with some compassion, well, I'm open to persuasion. So I think this is, if I can reach that, this little bit of interest. And honestly, I'm actually with Dan. It is possible that I spend the next 20 minutes with you on a topic that actually does not really exist. But on the other hand, if it does, I think it is worthwhile thinking about. I also must tell you that the original program, we invited somebody who is really an expert on this, both at the molecular, in vivo, human field, but she couldn't make it, so that's why I'm a substitute. So these are my disclosures, and I thought viral interference is something that is new, something that we never thought about, but that's actually not true. Viral interference is quite old. People have observed this more than 80 years ago in vitro as well as in vivo. And this is one of the first publications that I was able to track by Andrews in the British Journal of Experimental Pathology, that interference by one, it was a neurotropic virus in vitro, changed the growth of another virus in a tissue culture, but that was even expanded to animal work. So it's not new. The second thing I want to share with you, basically before I start presenting, that the word viral interference is a term that is not used the same way by everybody. It is used by epidemiologists sometimes to share the observation that viral epidemics rarely coincide. Just as an example, every infectious disease specialist in my own country knows that RSV precedes influenza epidemic. It's like very predictable. And then there is HMPV. So it is predictable and rarely coinciding, these viral waves in the winter season, as you can see here. Again, this was observed more than 40 years ago, that from the epidemiology, there is this observation that has now been translated to the COVID impact, that when COVID hit us, other viruses disappeared. I think from an epi point of view, you might refer to this as viral interference. One comes, the other one goes. And when the other one goes away, the virus comes back. So I think most of us will agree that this has something to do with non-pharmaceutical interventions, and that there is not interaction necessarily at the cellular mechanism. The last thing I want to share with you, I'm a pediatric infectious disease specialist, that you must think about viral interference when you read about or look at the airways of babies. I'm sure that many of you are familiar with the phenomenon that you can find several viruses at the same time in the airways of young babies, or as Heather described in a recent, or not so recent, Lancet paper from the Drakenstein study, a median of 5 organisms were reported in cases and controls. An organism was detected in about 97% of swabs from cases. This was just both viruses and bacteria, I realized that, but also often several viruses at the same time. In a study that we did in my institution, it was not, several years ago, it was not unusual to find 5 different viruses at the same time in infants in the first year of life. Specifically, the younger the children are, the more often you find several viruses, in particular rhinovirus. So it is impossible, when you read this, not to think about how do these viruses interact. It is impossible to think that they act on their own and have nothing to do with the other viruses. But how that works is not clear. And today I will talk about viral interference, but I think we have to appreciate as a model, as a concept, that there are at least 3 different ways viruses can interact. Interference, I'll talk about that in a second, but also synergy. One virus promotes outgrowth or transmission of another virus. Most of you are aware that RSV and many viruses actually suppress the innate immune system. So if you suppress the innate immune system, at least as a concept, it is possible that replication of other viruses is promoted. And of course, there is the concept there is no interaction, that they actually do act independently. I think, again, as a concept that I really support, if I read literature from as much as I've been doing over the past 25 years, I'm not sure that RSV co-infection, so if you find other viruses than just single RSV infection, changes the course of disease. There's a lot of literature pro and con. There's a major bias, but there is literature on human metapneumovirus co-infection, COVID. We heard from Asun, influenza, COVID, rhinovirus. All of these co-infections, sometimes you find that they change the natural course of disease, but altogether, it's just not clear to me. So even for no interaction, I think there is room. But what I want to discuss today, viral interference, is what I prepared many years ago for an RSV conference in Argentina. I just made this cartoon to make it at least clear to myself what I mean. It's interference at the cellular level. One virus infects epithelial cells, ciliated epithelial cells, possibly. These cells start to make type 1 interference, hence the word interference, and that makes the environment hostile for other viruses to replicate or to land at the epithelial site, and there is clear interaction with the innate, at least the innate immune system. Obviously, this is way too simple, but I just want to make it clear that this is more or less the concept that I would like to discuss today. So I will share some concepts that I got from literature, and let's see, maybe during Q&A, what you think of it. The first thing is that viral interference is complex. I think the best data, I'm not saying the most relevant data, but the best data are clearly coming from in vitro studies because you can control the experimental design. And then you can see here, co-infection in air-liquid interface models, SARS-CoV-2, influenza, SARS-CoV-2, RSV, and then hours post-infection from 0 to 96 hours, and here influenza with SARS-CoV-2 and RSV SARS-CoV-2. And we measure RSV or SARS-CoV-2. And you can actually see that if you infect with SARS-CoV-2 and influenza, then influenza changes the replication of SARS-CoV-2, really obviously. And the same is true for RSV. But conversely, looking at replication of flu and RSV, it doesn't change. This co-infection doesn't change the replication of influenza or RSV. So apparently, interaction is not always going both ways. Interesting that the concept doesn't apparently work both ways necessarily. This is a study in cell lines. I think you need to appreciate that there is a difference between using cell lines and and organoids or air liquid primary cell cultures. But this study, and I'll explain why cell lines were used in this study, there was a dose-dependent interaction between RSV and influenza. If the cells were pre-infected with RSV in a dose-dependent manner, you actually see a dose-dependent decrease of replication of influenza. And there are many studies, probably hundreds of studies now showing that this interaction occurs. And the question is, what is the mechanism behind this? Is this really interferon-driven? And to answer that in the most neat, the most specific way, you need to use a cell line. It's still very difficult to manipulate primary cell cultures, but in this case, the cell lines were knocked out for type 1 interferon receptors, and actually, indeed, it is dependent on type 1 interferon signaling. Here, it's the same study that I just showed you. You can see that RSV changes replication of influenza, and that by knocking out type 1 interference, this effect is taken away. So clearly showing that viral interference is dependent on interference signaling. So now we move to air-liquid interface models. And the pictures become better, that we start to see colors. And what you see here in blue is DAPI-stained cells, so these are all individual cells. And in green, you see human metapneumovirus, and in red, you see RSV. And it is very clear that cells are either red or green at the left side, right? There's no doubt about that. And if you would have cells to be co-infected with both RSV and HMPV, the cells would turn yellow. And that is exactly what happens if these primary cell cultures are treated with type 1 and type 3 interferon antibodies, blocking antibodies. Then you start to see individual cells that are co-infected with both HMPV and RSV. So I want you to notice that a single cell is infected with two viruses. It's really difficult to understand how that is possible if you think of the huge machinery that is induced by viral infection at the cellular level. This is another study, and I will show you why these types of studies still cast doubt on these observations. Again, an air-liquid interface, a similar type of in vitro model in which RSV interaction is studied. So one RSV strain is tagged green, the other one is tagged red. And here, the researchers, without type 1, type 3 interferon blocking antibodies, show that some cells are double infected. So different RSV strains apparently can infect the same cell. To me, that is still something that I find very difficult to understand, that a single cell at the same time is infected with two different viral strains. And even so, RSV interaction at the cellular level, at least in vitro, appears to occur. So let's move on to in vivo studies, from cell lines to primary cell cultures to animals, to study the time window for viral interference. It's not like a yes or a no phenomenon. Apparently, and I strongly believe that if viral interference is something that we should really consider from a clinical epidemiological point of view, that this is really something that's happening, then I'm pretty convinced that it is time dependent. And I think this study shows that nicely, where ferrets were infected with RSV prior to, influenza. And then what you can see here, that this is the normal viral kinetics. And by infecting these animals 3 days, 7 days, or 11 days before infection, you can actually see that if you infect these animals with influenza 3 days before RSV infection, you can actually see that the second infection is gone, completely gone. So now we can see here, this is in vivo viral interference, at least in ferrets. To me, it's very obvious that this is time dependent. If you take the time interval longer between RSV and influenza, then the effect is completely gone. I'm sure that there is still viruses that you can find at the same time. So it's not that the primary infection is completely gone, but it is clear that at the peak of the first infection, apparently there is so much, what I think, type 1 interferon or innate immunity or war zone going on that is very difficult for a second virus to start replicating there. So this theoretically might happen in humans as well. So let's have a look at human studies. This is work that Natalie did when she was with Shabir in South Africa, and Shabir is not here, but I'm fairly convinced that Shabir does not believe viral interference exists either, Dan. So you're in good company. Because he was not too enthusiastic to frame this finding as viral interference. But at least what was clear that if you look at RSV-infected children in a large cohort study, that if you find RSV, you don't find other viruses. So if you find RSV, the odds of finding rhinovirus or a human metapneumovirus, adenovirus, no matter how you look at it, you don't find the other virus. So it seems if you find RSV, you don't find another virus as an observation. I think it makes sense that if you're sick from one virus, the odds that you're sick from another virus at the same time is smaller. So I understand that this is not a proof that viral interference exists. Tina Hartert with Nick Achte studied viral interference in the US and looked at the odds of finding RSV and rhinovirus at the same time. Again, in an observational clinical study, it's not intervention studies, it's not necessarily proving mechanism, but no matter how they looked at it, again, adjusting for confounders, they showed that at different levels of care, the presence of RSV excluded the presence of rhinovirus. So from observational studies, let's slowly move to intervention studies. And I'm going to tell you that the answers from intervention studies are not yet there. So before you get your hopes high that I'm going to reveal the final answer, it's not going to happen today. I'm just going to share with you the paucity of data that we actually have. So this is very old data, 10 years ago, about a live trivalent intranasal influenza vaccine that showed in a post hoc analysis in a fairly small journal as compared to the original paper in the New England, that there was a slight increase of non-influenza respiratory episodes during the first year of the Belshi study. So it's the same authors that actually shared this observation that non-influenza respiratory episodes were seen as if there was some viral interference. If one is taken away, another one will pop up. But again, this is post hoc, just a single year. It's not convincing, but at least there is some evidence from trials. A similar observation by Ben Cowling from Hong Kong, doing an inactivated flu vaccine study and showing that non-influenza respiratory tract infections were increased in vaccinated versus placebo patients. This is getting closer to proof, right? So you vaccinate against flu and you start to see non-flu respiratory tract infections. This is more than 10 years ago, and there is not a lot of confirming literature on studies like this. I know that this is high quality work, but at the same time, I'm desperately looking for confirmatory studies to show that this phenomenon is real and that this is something that we should consider when we start to use RSV vaccines. So coming to RSV now, so these were all flu studies. Coming to RSV, 10 years ago, we published a paper on RSV and wheeze and asthma. Was not meant to study viral interference at all, but what we found was that in the swabs from children with respiratory episodes, we found more other viruses, more co-infections, and highly statistically significant. The p-values are smaller than 0.05, but for many viruses it was smaller than 0.0001, and there was a clear difference in RSV positivity, not episodes, but we did find other viruses, and we tried to link that to, for example, an in vitro artifact, but we couldn't demonstrate it actually. So I think, at least in this placebo-controlled trial with palivizumab, we could not exclude that there indeed is some form of viral interference, although it was not considered a safety signal, which I think is an important message here when we start to talk about viral interference. So the current RSV trial evidence. All these large RSV vaccine trials so far have not shown any evidence of RSV interference. There are a few remarks that I want to make. First is that, to the best of my knowledge, but I'm very open to hear from companies whether this is correct, I don't think the regulators require pharmaceutical companies to check for viral interference. I think it is acceptable to focus on the pathogen that you study and not necessarily study the viruses that are not vaccinated, against which you don't vaccinate. So I think viral interference is not necessarily something the regulators want you to study. Therefore, there is little data. I remember, I see Vivek here, that we talked about this quite lengthy at the early days of the Novavax RSV vaccine trial, and I think you convinced me that there was no evidence in the Novavax, if any, the opposite. He's nodding, so so there is little data, but I think there is opportunity. We have so much data. I think all these companies now have thousands of freezers full of swabs, and I think there's opportunity to study this. So I really encourage that, and I don't think there is a warning signal, so a safety signal. So I really want to share that message again before I'm misinterpreted or misquoted. So what I've shown you is at the molecular level, there is very clear evidence in high-quality primary cell culture system that interference exists, and type 1 and type 3 interference are definitely an important mechanism. There are animal studies, and there's more than what I showed, supporting that concept that it is time-dependent. Probably a few days after infection, there is the peak of interference in an in vivo system. From observational studies, we have the evidence, but as I tried to explain, for RSV studies, the trial evidence is really poor, and the fact that it is poor, let's say, supports the concept of then that maybe it's not even existing, but there's so much noise in this field that we thought it was interesting discussing it. These are the people I would like to acknowledge: the Resvinet Foundation, the RSV Research Group, Dan, always telling me that I'm doing the wrong things, and his team, and Shabir, who again was not supporting the concept, and Tina, at least somebody who is supportive of the idea that it's worthwhile discussing. Thank you.
Thank you very much, Luis, for this interesting talk. Many questions are still open, so may I ask to the audience if there are questions for Professor Bond, please.
Yeah.
Is the mic on?
Yeah, now it's
okay. Yeah, so I'll just defend myself a bit. So I think that was a very convincing set of evidence. I think the disconnect is what might be happening on the individual level versus the population dynamics, and I think that's the gap that we have to answer, is whether sort of what we're seeing on the cellular and maybe even on the individual level in terms of interference might transfer into sort of these population level interactions in sort of the time series that you were showing at the beginning. I think that's where we need more evidence, perhaps.
Fair point. So before jumping from individual level to population level, it's a big jump that I did. So thank you. Vivek?
Go ahead.
Oh.
Thank you, Louis. So, you know, it looks like you hire me to ask questions in every session, but full disclosure that you didn't tell me that. Anyway, the point is that we are surprised. When we began to test in the last 10 years consistently with the multiplex PCRs, we are surprised how many times we see more than one virus, right? So is that challenging the concept of interference?
So the fact that you find so many viruses just means that it's very busy. I think the microbiome people say, well, you find 10 viruses, we find 1,000 different bacteria. So the fact that they're there, it's like this room, right? There are so many people in one room, but it doesn't mean there is interaction. Now there's interaction, but I was just talking to you without, so interaction is not the same as being present at the same time. And yeah, I really don't know. So what are your thoughts, Octavio? Give us, I'm sure people want to know that.
Yeah, right. I have 4 hours. Anyway, do you think, the big question that everybody asked you, I'm sure, and we are going to take care of RSV. I think we are not there yet. We have talked about this last night a lot. Maybe with 3 glasses of wine, we were brilliant about it. But the people were asking, is something coming after that, right? That's the big issue. If we suppress RSV to not be such a major problem, will metapneumo or paraflu will be the next? What are your thoughts about it?
Yeah, so I think we need a few more years. So my guess is not really. I think we will find, as a proportion, we will find more other viruses like influenza or human metapneumovirus, etc. But I don't think we're going to see what bacteriologists call replacement. I think that is completely different. So I'm not convinced that if you take out one virus, you're really going to see a surgence of an increase of other viruses at a population level. A few more years.
Yeah, thanks, Louis. Yeah, just to confirm, I mean, we saw a pretty strong signal in the opposite direction in the phase 2 trial where we did see efficacy. And the most notable place where that signal was rhinovirus. And I think at the time it was, about a 30% reduction in rhinovirus, the most frequently isolated pathogen. And these were large numbers, not small numbers, and 2,000 people. And about a 30% very highly significant reduction in rhinovirus. We saw it in some other viruses like HMPV as well. And I think at the time Tony hypothesized that the interaction going in the other direction was, perhaps in those you're preventing RSV infection, you're not getting the upregulation of ICAM receptors, which are needed for, which are like the universal receptor for rhinovirus. So intervening is preventing some downstream action that creates susceptibility to other viruses. So just one data point, but it was a pretty strong signal.
Yeah, so the point is taken, and I showed one slide about synergy. I think maybe next meeting we have a lecture on synergy, rather than interference. I think you're right. This is possible. Yeah, thank you for sharing.
I'm sorry, but we have a discussion also at the end of a section, so the last one, please.
Hi, nice lecture. Raj Salvarangan from Children's Mercy, Kansas City. We had a similar observation, so I think the point about what happens at the individual level and at population level is to try to connect those dots. But there's an additional layer is probably the kinetics of the virus, depending on, for example, when RSV showed up in July 2021 in US, there was no, issues with both RSV and SARS-CoV-2 co-circulating at a good level. The peaks almost were superimposable. But then a few months later, influenza comes in, and then you have the Omicron wave, when SARS-CoV-2 really took off, flu came down, and then there was a few weeks to month before you saw a second peak. So there's something about the kinetics. It kind of makes sense that at the individual, it's almost like the herd immunity. You have a group of individuals infected, and at a certain point, then the other virus does not get to co-circulate. So any thoughts on that?
Yeah, so thank you for bringing that up. So the observations from the interaction between COVID and RSV were actually discussed by Asun. I know she's here somewhere. And my take on this, and we have actually a fairly good investment in understanding RSV-COVID interaction at the epi level, is that every country, or in the US maybe they see something different. So we feel that what we see is real. One goes up, the other one goes down, or both come at the same time. It's related to one intervention, but to me it appears, because the word was far from stable, that we have our own reality. So what is true in Kansas may not be true in France. It's just, so it's still early. We need to find out. I thought, I'm sure as soon remember, you don't have time to come to the microphone. I see Eugenio looks very serious now. But you could actually see that one peak, there was RSV and COVID at the same time, and the other time it was independent. So we all have our own realities, maybe for next year. Thank you.
Again, thank you very much, Luis. And now it is a pleasure to ask Professor Dagan to present his talk about bacterial pneumonia. Please.
I have a lot to say about the previous talk, but it would kill my talk, so I need to have some time to give my talk. So I'm going to talk to you about some insights I think I gained through the pandemic about RS virus and pneumococcus. So the COVID is just a pretext here. I'm actually talking about pneumococcus and RS virus and some other viruses that are related also. This is my disclosure. And let me start with this slide. I was a fellow in Rochester, New York. A very dominant person in RS virus was Caroline Hall. Dear teacher, dear investigator, dear person, and a very stubborn one. And she had a paradigm that everybody carried for more than 20 years and long, and this says, we conclude that the risk of secondary bacterial infection appears to be low for most infants with RS virus infection. And I hear this until today. Fortunately, I have some friends now who believe differently. I never believed this paradigm at all. Now, is respiratory infection like pneumonia bacterial infection? We usually don't see the bacteria, but we do know that the pneumococcal conjugate vaccines have shown us a lot about how much bacterial is pneumonia. So if you go for alveolar pneumonia or lobar pneumonia, we can, as we show here in our surveillance in Israel, prospective surveillance, you can really cut 50% of alveolar pneumonia once you introduce the PCV. And if you go now reverse calculation, at least 50% of this is vaccine type. and at least 75% of alveolar pneumonia is pneumococcus. So alveolar the pneumonia is pneumococcus, as the old people always thought. If you go for now, for those who are not alveolar, but lower respiratory infections, bringing children under 5 to the hospital and needing an X-ray, then PCVs did in many, many places what we see here, about 25 to 35% reduction. Again, by going reverse, this is about 50% where pneumococcus plays a role. So those are bacterial, not always bacterial, but also bacterial and mainly pneumococcal. So pneumonias are pneumococcal disease more often than not. Are they viral? So we have a lot of papers showing things about viruses and pneumonia, and what is pneumonia is another issue to argue, but what this, I was going to go to bring some other slide, but this is just a few days ago appeared in PIDJ, so I thought another one comes with the same message from Norway. You can see these 4 viruses, RS virus, HMPV, flu, and paraflu, are the ones that are associated strongly with pneumonia, and the king is RS virus. The others are not associated with pneumonia. That's usually what you see in most papers coming out. So I call these viruses pneumonia viruses because they are mostly and more often associated with pneumonia. Now, RS virus is the most important that was suggested to be associated with pneumonia. And we come back now to the question, can you do something with bacterial vaccine to reduce RS virus if they are really coming together with pneumococcus? So this is a paper by Dan Warburger. It's not the only paper that talks about it, but it was very clearly seen that if you give PCV to the population, you have an impact on admission with RS virus infections. So that means if PCV can reduce admission with RS virus, there is a co-infection. And the co-infection with pneumococcus and RS virus was very well established actually by the effect of PCVs on RS virus and on some other viruses too. But as you can see, these 2 birds talking, one bird tells to the other, this definitely shows that RS virus and pneumococcus co-infection is common. But the more wise one, I think, at least the older one, says yes. But does this really prove that RS virus contributes to pneumococcal disease beyond what pneumococcus is there? Because if pneumococcus and RS virus are co-infection, and you reduce pneumococcus, and you reduce admission for pneumococcus, you will automatically reduce admission for RS virus because they are just there together. Do you really have the role of the RS virus that makes the pneumococcus more severe disease? If you want to do this, you need to take the other part of the equation and take the RS virus and see what happens to the pneumococcus. And then you have the 2 sides of the equation. Now, how can you do this? Easy to think about, okay? You just have the 4 viruses I just mentioned, okay? You have pneumococcal carriage, which is the source for pneumococcal disease. You reduce all the 4 viruses from the circulation in the community at the same time to almost 0. You keep the carriage, and then you see what happens. Easy. And then, if you really want to complete, get them come back out of season, because then you take away the winter issue, and then give them 1 by 1 to come back, because then you can look at each one of this, what they do, and then see what happens, and then you complete your study. Anybody can do this? No. COVID can do this? Yes. So COVID did it, okay? We can say God did it, COVID did it, whatever, nature did it, but this is what COVID did. So now we can look at the results if you have a prospective surveillance that is going on in your place. And that is what we have for pneumococcus, not for COVID or whatever. So 1, do we keep the carriage stable? Yes. We have published part of it. Now it's going to be published even more complete, but this is a proportion of children carrying pneumococcus. Under 3 years of age, we take children every single working day for many, many years. You have thousands and thousands of those. You can see that this is anything between 40 to 60%. This is the 3 years that we have in the COVID. In blue is the 4 years before the COVID. And whenever you see these blue things, This is the minimum, the maximum, and the mean, and you can see that this is the expected from the previous 4 years, and you see about the same carriage, a little bit less here, a little bit less here, but this shows that if there is something less, it's the lower density carriage as measured by semi-quantitative. The higher density still stays there the same. Is it different serotypes? This is the serotype distribution every single year, and you can see exactly the serotype distribution. So we kept the carriage constant, so that is a condition for the study. The other condition is take the viruses. This is, you've heard about this a lot, but this is what we had in our place where we looked at this natural study. So again, each one of these viruses in red are the pneumonia viruses. In blue is the maximum, minimum, and the mean for the 4 years before, and this is the expected first winter 2021, and you can see the RS virus went down to completely zero, flu B 0, HMPV 0, and paraflu 0, but then started to come before the others back. While respiratory adenovirus, rhinovirus didn't do anything, they would not expect them to do anything. Not only this, they continue to circulate like crazy during COVID. So the ones that we wanted them to go down for the experiment did go down. Now, how did they come back? Did they come back together? They came out of season, we all know this, but look at this. This is where paraflu came back. You see it here. Next, we have HMPV that came back a little bit out of season. Then we have RS virus who came back in the summer rather than in the winter. Then we have flu A that came late in the back, a little bit actually before the season back, but not together with the other viruses. And flu B actually only came 3 months ago and a little bit. So yes, one by one, out of season, excellent. So all the conditions for the experiments are great. What happened to the pneumococcal-associated disease? We have 4 outcomes in children under 5 years with our prospective study. One is community-acquired alveolar pneumonia, so this is the lobar pneumonia. This is the non-alveolar or the LRIs that had X-ray without any consolidation. This is the pneumococcal bacteremic pneumonia, which is the prospective study on invasive disease that we do in Israel. A third had a diagnosis of pneumonia also, and this is all the IPDs that did not have any respiratory issue. And you can see this very, very deep repression of alveolar pneumonia and this resurgence out of season, and then coming to sort of synchronize in a very strong year this December and January. If you look at the non-CAP, they had exactly the same pattern, but they usually have a pattern that doesn't go down in the summer to the end. If you look at the pneumococcal bacteremic pneumonia, there are less cases, so it's a little bit more jumpy, but it follows exactly the alveolar non-bacteremic pneumonia. And the only one that doesn't really care about the RS virus, at least with this graph, is the non-pneumonia IPD. It goes the way it goes. Forget about the rest. So if I now clump all the pneumonia viruses together and look at every year, so as you can see every year, similar pattern, are not identical, never identical, but similar pattern every winter until they come to the corona. There is nothing here, and then you see this crazy pattern never seen before and probably never will see again. How does this look graphically when you compare it to alveolar pneumonia under the age of 5? This is a striking similarity. It's like 1 to 1. You don't need to be a genius to know that this is a very strong correlation. But we still wanted to know, Dan Weinberg and me, whether how to take it by age and how to have quantitatively attributable for each virus what we see here. So then help with the model, and we basically, you see here different ages, and you see, so first year of life, second year of life, third to fifth year of life, you see the 4 entities, and you see the viruses that we did. For rhinovirus, we did it separate because we started to look for rhino later, but there was no correlation. Adeno, immediately I can tell you there was no correlation whatsoever for anything. But for CAP, you can see that in the first year of life, RS virus accounted or was attributable to 62%. Two-thirds of the cases of alveolar pneumonia in the first year were attributable to RS virus, half in the second year, and a third in the third to the fifth year. If you look at RS virus in non-CAP LRI, 30%, 16%, and 50%. If you look at the pneumococcal bacteremic pneumonia, it was mainly in the second year, but it was there, not quite reaching significance, but it was there. And when you go for non-pneumonia IPD, nothing. So this is really the respiratory pneumococcus-associated disease were very strong with RS virus. HMPV was strong for pneumonia, was nothing for the rest. And flu and parainfluenza also were strong for pneumonia, nothing for else. But RS virus was very strong there. But this is proportions. If you really want to look at the attributable amount of cases, then you have to take also the incidence, and we had the incidence, and Dan showed part of this in his talk. You actually look in 2021, because the model was how this is going to be in 2021. You look in 2021, you can see that of all CAPs, in orange is the RS virus. First year was the highest rate. You can see that RS virus really dominated the lobar pneumonias, which is the pneumococcal disease. Dominated lobar pneumonias in the first year, second year of life, and even the third to fifth, it was important. If you go for non-CAP, the only virus that had a real big presence here is RS virus. If you go for IPD pneumonia, so invasive disease with pneumonia, again, RS virus is the most important. And if you go for IPD, invasive disease, pneumococcal disease, without respiratory problem, RS virus is absent. So RS virus is extremely important in all pneumococcal-associated diseases that are respiratory. There is no doubt about it. We were happy with this, but I always want to see where am I wrong, if am I wrong. And so I discussed with Dan, and I said, Dan, you know what, 22, we never did this for 22. 22 is over now. I send you the viral activities in our region in 22. You look at it, and you tell me whether what happened with its outcomes, because then we may be happy with the model. So this is the model for all the years that I just showed you now. The blue is the expected, the orange is the reality, and 22, you can see for pneumonia, Dan was exactly there. It was a little bit stronger than Dan was predicted, but otherwise everything was very strong. For the observed, this was not exactly, it was a pattern, but also I forgot to show you when I showed you the outcomes also. After Corona, we started to have more X-ray done because we're not after Corona, we still have Corona around. We do more X-rays, and if there is no consolidation, they're still around by the definition. So this is expected to be a little bit higher, but the pattern is exactly the same. For IPD pneumonia, we have exactly the same pattern, although we don't have the last 2 months. It takes some time to collect from the rest of the country. And for the respiratory IPD, anyhow, it goes the way it goes, independent. So the model did predict appropriately even the 22, so the model actually is correct. An attributable role of these viruses, especially RS virus, in what we call bacterial pneumonia is now, I believe, proven because you have the two sides now of the picture. Actually, this is, I think, the most beautiful slide I ever produced in my life, okay? I'm not saying that I have beautiful slides, but this is the most one, okay? And if you look, this is the prospective data on pneumonia, alveolar pneumonia, surveillance since 2004 until 2022, so almost 20 years. You can see the winter peaks every year, very stable. This is the rates per thousand. We get the PCVs, it goes 50% abrupt, and this is not only in Israel. So this is the proof that this is bacterial infection. But then comes this RS virus reduction with some other viruses, and you see bonk down, and then resurgence with the viruses. So you actually see really that alveolar pneumonias is a co-infection, a real one with the co-contributors, and this is, I think, now we can talk about it in a very, very positive way. Now, I had more questions because this, I already showed part of it before, and without being provocative, I'm not on the gun. So I have another issue here. This is looking at children under 12 months and looking what happened in pneumonia in the first year of the COVID and the second year of the COVID when the virus started to go back. So, and this is cumulative. So in the 4 years before, children under 12 months, this is how cumulatively they, and I go from March to February rather than the regular month because this is a COVID year from March to February. That's how it started. So usually when you go, you see this is the cumulative incidence. In the first year, we had 80% reduction of the pneumonias, as I showed you graphically before. In the second year of the COVID, when I take now the new cohort of children under 1, they start very low, but then the viruses come in and they do catch up, and they come exactly to 1. And that's important, because these children are born to mothers who did not see RS virus. So these children are born with lower antibodies than anybody at any other cohort ever, okay? But they do catch up exactly the same. What happened to children that are 12 to 23, second year of life? Usually they are already exposed to RS virus the year before. So this is usually what you can see. In the first year, nothing. So they were not exposed to RS virus, there was no RS virus, also no pneumonia. Now, in the same age now, in the second COVID year, they do beautiful increase, but now they are 60% more. These are exactly the same. Here, if you're second year, you're 60% more. So why are you 60% more while the first year is not? Is it because you have different viruses that circulate around, and maybe because HMPV is bigger, which is going maybe to the second year more? We ruled this out very easily. We just took all the positive viruses that we had. You see the numbers of tested, quite big numbers every year. So the 2022 compared to the pre-corona, exactly the same. So no different distribution. So why is it so? The only speculation I can have at the moment, and it's a speculation, is that these children were not exposed to RS virus the year before at all. So you may keep some immunity to RS virus, which may then make you less susceptible to the secondary effect of RS virus, such as pneumonia. So this is a speculation. It needs to be tested with other models in other places, but I think this is one question I want to raise. The other question is, now if you take a child that comes from a cohort, this is a cohort, the first cohort that is a first-year cohort, as I showed before, but now the same cohort is seen in the year after, because we have that. And so you have now an increase, some catch-up, but even with this catch-up, IRR was 0.21. Now it's still 0.69, so it's still 30% less. So they did the catch-up, 60% more than usual, but they still did not reach the cumulative to the end. Why is that so? They are not immune to RS virus from before. So is it now the age? Probably the age has to do something. When you have an RS virus in the first year, you may be more susceptible to pneumonia than if you have RS virus in the second year. So I think that what we see here, we see not proof, but we see a very strong suggestion for dual mechanisms of things. The age effect, which is pure from the previous RS virus thing, and maybe if you do not have RS virus, you are more susceptible. So this is some provocation for the next ideas to try to look at this type of co-infection. So I can summarize by saying that the unique opportunity to prospectively observe simultaneously and in the same population the COVID-induced dynamics of viral activity and pneumococcal-associated disease elicited new insight on viral-bacterial interactions. I think that the viral co-infection seems to be the rule rather than the exception in early childhood bacterial pneumonia. And that's very important for clinicians, not us, we are RS-virus people, but clinicians. They still live in this dream that if you show a virus, you have not to give antibiotics, because if it's viral, it's not bacterial. Remember Karen Hall. If it's viral, it's much more likely to be bacterial than if you don't see the virus. So that is one thing. So stop testing viruses in order not to give antibiotics. That's not the point. The relative attributable fraction of the LRI-associated viruses varied by age. However, in all ages, RS virus was the major causative player in pneumonia and other pneumococcal-related respiratory infections. So this is the message for us. We can be proud. You are the RS virus society. I come from the pneumococcus. I am proudly joining you because it's the king. The third one, I think, is very important too. It is suggested that RS virus vaccines might be an ideal anti-pneumococcal vaccine. Not only because you see what happens when they're not there, but all the pneumococcal vaccines so far are conjugates, and they really harm the flora. They take viruses, they take serotypes out. You have replacement that come in. We know that the microbiome is changing because of these vaccines, because now we have more Haemophilus influenza because the serotypes that come in are more interacting. There are so many more changes, and how much can you go with more serotypes before you start to actually harm the normal flora that God gave you as a pneumococcus? But this one did not touch the flora. We showed it. The carriage was the same. So that's actually a nice thing to think about, and that can be tested when we start to vaccinate against RS virus. And the last point that I am asking now, it's more provocative, but it's something to be asked. Our findings hint that exposure to RS virus during the first year of life may reduce pneumonia in the second year of life. It could be also vaccination, but active, not passive. So we have to think about the potential secondary benefits of active vaccination in the first year of life with RS virus vaccine, which may be then, like many other vaccines that we saw, giving us some good surprises that will be helpful for whoever likes to do cost-benefit and other analysis. So I think this is my last message, but this goes together with my main conclusion in life, that the chief aim of interpretation is not instruction, but provocation. And maybe what I like best is this one. The important thing in science is not so much to obtain new facts as to discover new ways of thinking about them. Thank you very much.
Thank you very much, Ron, for this stimulating and provocative talk and for your personal contribution to this topic. Unfortunately, we have time for just one question because you are a little bit late. No question?
Eugenio, Harish here. Thank you, Ron. It's a very provocative talk. I think the statement that you made around antibiotic prescription, I think that's even more provocative than your findings itself. And I'm wondering, particularly with regard to what the WHO is thinking around changing the IMCI guidelines to reduce antibiotic prescriptions, this goes slightly counter to that. Do you...
Wait, you say it's going against or for?
No, so if you're saying all viral infections, or when you detect viruses, there is a bacterial infection, and therefore you should not withhold antibiotics, you should give. I think that's the message I got. Maybe
no, you should not say that if you have a virus, you should not give antibiotics. You should become again clinician and give antibiotics to those who need antibiotics.
Yeah. So the question I have is whether it is co-infection or the pneumococcus comes after RSV. So is RSV sort of a priming?
No, I think, this is a co-infection because we basically detect this virus. Okay, I didn't bring I mean, I already had 3 minutes over time. But if I had time, I would have brought you our data from the cases of alveolar pneumonia from whom we tested the viruses, and it mirrors this. Most of the cases, 65 to 75% of the pneumonia cases will have these viruses with the same actually proportions as the activity. Now, many of them have rhinovirus and adenovirus and coronavirus, not COVID-19, but coronaviruses, etc. They come at co-infection, they come at single infection. This is why I'm not sure that interference is the same for each virus against each virus, and they don't do anything to pneumonia. But those viruses are rarely coming as a co-infection with each other, and they are really detected in most cases of alveolar pneumonias.
Can I just, Heather, hi. I'm eating into my own time, so that's okay. Ron, is there a severity effect, though, to link Harisha's comment about who should get antibiotics or not? You know, currently IMCI recommends that if you've got fast breathing, you get antibiotics. So is there a severity effect in terms of pneumococcal RSV interaction and who should get antibiotics?
I will tell you, if you see a child with lobar pneumonia, you give antibiotics. They respond in 2 days to antibiotics. This is bacterial infection. This bacterial infection responds to antibiotics, and all of us give antibiotics to lobar pneumonias, okay? They have viruses, but we cannot say they are viral pneumonias. There are viral pneumonias, and we get antibiotics. If you see a child with LRI that does not have consolidation, that always I preached, give antibiotics to those who need antibiotics. If the child is sick, has 40 degrees of fever, 25,000 leukocytes, and looks sick, you have to treat the child with antibiotics. If the child wheezes with 37.9 degrees of fever and is a classical bronchiolitis and not else, don't give antibiotics. However, he might have a bacterial infection. Now, we don't treat all bacterial infections with antibiotics. I don't know if you know, but studies show that 30 to 40% of the common colds are actually, you can shorten them with antibiotics because they are also bacterial. So what? So you give antibiotic to them. So be clinician. Treat those who need, but don't come with this automatic thing that says now viral versus bacterial. That is something which is, for me, dead.
Okay, thank you again. And I give Ron, please, I give you the microphone to introduce the next speakers.
Yeah, actually my role is to call on you, Heather. So I did not forget you, I just forget myself.
Good morning, everyone. Thank you very much to Louis and his great team for this invitation to be here and to speak today. It's been a fantastic meeting, and it's a great privilege to be here today. I'm going to talk about long-term effects, asthma and wheezing, primarily following RSV. These are my declaration of interests. And I'm going to cover some of the evidence for the association of RSV, lower respiratory tract infection, with recurrent wheezing, with asthma, with a few words about recurrent LRTI following an episode, lung function impairment, and other long-term effects. And I'm going to address the issue of is this causality or susceptibility, and some brief words about mechanism. So there are numerous studies that have shown an association between RSV, lower respiratory tract infection, so this is disease, and recurrent wheezing. And these are two meta-analyses. Am I impaired? Oh, sorry. Wrong button. And you can see odds ratios of around 4, 2 and this is the lower meta-analysis is for RSV infection, not necessarily disease, with recurrent wheeze. And so you can see these are odds ratios of 2 to 4 for the association of recurrent wheeze. More recent meta-analysis from Steve Brunwasser and Tino Hartwitz's group, an adjusted odds ratio of around 4, similar to what I've shown in the previous slide. And a meta-analysis for the association of RSV, lower respiratory tract infection, and asthma risk, and again, an odds ratio down there, pooling all the studies, of around 4. But we must note that most of these studies, in fact almost all on this slide, are from high-income countries, and there's very limited data from low middle-income countries, despite what we've heard over and over again, the huge burden of RSV LRTI lying in these areas. What do immunoprophylaxis studies show us? And here the evidence is a little bit controversial. So there's different evidence from the randomized controlled trials we have. There are 2 quite different trials. The trial by Kate O'Brien, different product, and in healthy term infants, followed, I think, out to about 3 years, showed no increase in recurrent wheeze. Or serious wheeze, although the prevalence of wheeze was quite low. And then in the study, the Mackey study that we've heard about many times through this conference, in fact, the outcomes at 6 years of age were some increase in parentally reported wheeze, but no increase in physician-diagnosed asthma and no difference in lung function, which I'll show you later. And then again, observational studies, and I'm not going to go through all of them, different estimates depending on which study you look at, and overall you can see no strong evidence for the association one way or another. Now, why is this? And I think one of the first problems that we have is we're lumping everything wheeze as a single group. And we now know from numerous birth cohort studies, most in high-income countries again, that wheeze is a very heterogeneous disease. And here, as is asthma, and this was the Lancet Commission on Asthma, and you see here different phenotypes from birth going through adulthood, and you can see 4 or 5 different kinds of phenotypes described: early transient wheeze, late onset wheeze, persistent wheeze, etc. Some of you will be familiar with those, and with variable relationships to viral lower respiratory tract infection. Now, I want to share with you some of our recent data. Louis mentioned the Drakenstein Child Health Study. This is a birth cohort in a low middle income country setting, South Africa. We enrolled about 1,000 pregnant women, followed them from birth, and the children are now around 10 years of age. And every time a child got a lower respiratory tract infection or wheezing episode, we did a multiplex PCR for etiology. And we also measured lung function, and this is important, from birth through childhood, so that we could look at the impact of early life LRTI and RSV LRTI in particular on chronic lung disease. And so here are the wheezing phenotypes that we found in this low middle income country setting. And you can see again 4 wheezing phenotypes, not dissimilar to what has been described in high income countries. Around 50% of children never wheeze. This is in the first 5 years of life. And then you have these 3 other wheezing phenotypes: early transient wheeze, about 1/4 of children; late onset wheeze over here occurring after 12 months, around 11%, and this group of recurrent wheeze around 16%. And I just want to draw your attention to the association with RSV LRTI in each of these wheezing phenotypes, and I'll show you the more detailed data. But before I show you that, how does that compare with high-income country wheezing phenotypes? And this, you see here, the wheezing phenotypes from the biggest UK birth cohort, LSPAC, that is led by Adnan Kustovic, and in which we use the identical methodology for deriving phenotypes. And you see there are some differences. There are 5 phenotypes in LSPAC. The ones that are in red are common to both, but Drakenstein has 4 phenotypes, and then the distribution is very different. While the proportion of children who wheeze in each is similar, around 50% in each, you can see that the prevalence of wheezing at all time points actually Here in Elsbeck, from 6 months to 69 months, is higher in Elsbeck than in Drakenstein. And the peak prevalence of wheezing in Elsbeck is around, is within the first year. In Drakenstein, the peak prevalence is around 13%. So these are the detailed, this is the multivariate analysis of the association with wheezing phenotypes in Drakenstein. And to point out two results that I want to highlight: the number of lower respiratory tract infections strongly associated with all three of those wheezing phenotypes, and RSV, lower respiratory tract infection, stands out as a key association with each of those three wheezing phenotypes. Now, the reason I'm also highlighting repeated LRTI is we'd previously shown, and I think this is also relevant to the discussion of what follows RSV LRTI in terms of other viral or other bacterial LRTIs, is that a child who developed an early life RSV LRTI had a threefold risk of developing recurrent LRTI, non-RSV LRTI, within the first 2 years of life. And this was highest when stratified by severity, so for hospitalized RSV LRTI. And so I think this is maybe a key thing that we've underestimated in terms of the impact of RSV on subsequent respiratory health. Now, this has also been shown to an extent by Tina Harted's group, and this is data from a huge cohort in Tennessee. It's over 123,000 children, infants actually, who were followed through the first year of life. And this follows children for the development of pneumonia, otitis media, or antibiotics. These are children who were followed for, who developed bronchiolitis in the first 6 months of life or did not develop bronchiolitis in the first 6 months of life, and then the association of pneumonia, otitis media, or antibiotics in the subsequent 6 months. And so you can see here the 4 categories: no RSV bronchiolitis, then outpatient visit for RSV bronchiolitis, emergency visit for RSV bronchiolitis, and hospitalization for RSV bronchiolitis, these all within the first 6 months of life. And what you see is a clear dose-dependent effect. The children who are hospitalized for RSV bronchiolitis in the first 6 months of life had a much higher risk, an adjusted odds ratio of about 1.63 for subsequent pneumonia, non-RSV pneumonia in the second 6 months of life. And you see there's an effect on otitis media and antibiotic refills, which actually mirror each other, really, I think, probably reflecting the same thing, but not a dose-dependent effect. Okay, so we're still left with this question of what is the mechanism? How does this work? And I guess there are 3 possible models for this association of RSV and subsequent wheezing or asthma. Either RSV directly causes wheezing illness, or both reflect underlying susceptibility, or both of these mechanisms may be at play. And can we answer that? And so this is the same meta-analysis that I showed you from Steve Brumman-Wasser, adjusting for genetic susceptibility. And so this uses, here you can see the analysis that I showed you before, an odds ratio of about 4 for the association of RSV-LRTI with subsequent wheezing, and here adjusted for genetic confounding. And just to point out that in most of these studies, it's an imperfect measure of genetic confounding. It's a family history or maternal history of asthma or wheezing. And this is a small study, but this is a single small study of monozygotic twins who had discordant RSV status and were then followed for recurrent wheezing, and there's absolutely no association here. So this is consistent with genetic susceptibility at least being part of the story. What is actually needed to establish causality? And I think there are these 3 factors. We need to show a temporal relationship, and this has been shown in many studies. RSV precedes the development of asthma in many longitudinal studies. We need to show a dose-dependent effect, and I've shown you some of the data, I'll show you a bit more, that hospitalization is associated with, is a stronger association. And there are many studies that show this. And then is there an underlying biological mechanism? And sorry, I don't have time to go into this, but there are numerous studies, I've listed some of them here, that show an aberrant immunological response to RSV in the epithelium, and innate immunity may result in reprogramming of immune processes and airway epithelium that may result in recurrent wheezing or asthma, more so in susceptible individuals. And this is a nice recent review, and it shows the factors that have already been associated with TH2, TH17 predominant immune response and asthma development in the context of severe RSV infection, these and the unknown factors, as well as those that may be protective. So is this association specific to RSV? And there's been some discussion about other viruses. And here's a recent meta-analysis that looked at the comparison of RSV bronchiolitis versus rhinovirus bronchiolitis and the association with recurrent wheeze or asthma. And in fact, what this meta-analysis showed was that the association for rhinovirus bronchiolitis was much higher than the association for RSV bronchiolitis, both for recurrent wheeze and for asthma. So it doesn't, now rhinovirus is a particular virus, and rhinovirus C particularly has been implicated in terms of recurrent wheeze or asthma, but it is likely that both of these viruses may play a role in the development of recurrent wheeze or asthma. Can we learn more from lung function studies? And again, these are plagued by different methodologies, different times of measurement only after the event. And I'm highlighting this, and these are pictures from Drakenstein, to show you that you actually, to answer this question, one needs lung function preceding the episode of LRTI. And here you see us doing lung function in the 4-week-old baby using a forced oscillation technique. And then now in older children, again with FOT, but also with spirometry and other methods. And your outcome is as good as your measurement, right? So let me show you some of the data, and this will highlight the limitations of the data. This is a meta-analysis of the impact on lung function of RSV-LRTI done by Charles Vevey, who's actually here, and Marta. And again, the message, 31 studies, wide heterogeneity, difference in inclusion criteria, difference in measurements, difference in follow-up periods, no premorbid lung function in any of these. Very difficult to make sense of any of this data, so much so that the data couldn't even be pooled. And these are predominantly spirometry studies. What about some of the prospective studies we have? Again, the Mackey study I mentioned before did not show a difference in lung function at 6 years, and these were preterm infants either assigned to palivizumab or placebo, so no difference between those two groups. And I want to again show you some data from our study, because we do have premorbid lung function in the study. And the bottom line from the study are that LRTI, all-cause LRTI, impairs lung function, but is non-specific to RSV. And let me show you some of that data. So this is the data comparing children, lung function at 2 years in children who had LRTI versus no LRTI, RSV LRTI versus non-RSV LRTI. And what you see is that children who had LRTI had a higher respiratory rate and a reduced compliance at 2 years of age. But there was no difference when you compared RSV LRTI to non-RSV LRTI. And this is a really important finding, I think, that for each additional LRTI, there's an incremental effect. And given that I showed you that RSV is associated with recurrent LRTI, this may be an indirect effect of RSV. This effect was controlled for baseline lung function, independent of baseline lung function. So it's not that children who have impaired lung function get RSV or get LRTI, but rather that LRTI itself impairs lung function. And how does this relate to the wheezing phenotypes? And here again, you see, and now this is airway resistance measured at 5 years for the 4 wheezing phenotypes that I showed you in Drakenstein. Here you see the highest, and the two graphs are 6-week lung function versus the 5-year lung function. And what you see in children who had recurrent wheezing, which we believe is the phenotype that will go on to asthma, they have the highest airway resistance, and they have a big increase in their airway resistance from 6 weeks to 5 years. And it's shown here. This is again, this is a statistical relationship. If you compare the 3 wheezing phenotypes to children who didn't wheeze, those who had early transient wheeze have higher resistance, but those who had recurrent wheeze have the highest resistance at 5 years of age. So the greatest impact in terms of lung function was seen in those with recurrent wheeze. Oh, sorry. Okay, fine. I want to finish with a few thoughts about the more long-term impact, and this may be going a little bit beyond what I was asked to address, but I think this is important to consider. And we now know from numerous studies that early life lung function, sorry, there's a thing missing here, yeah. Early life sets a trajectory for lung health. And this is from the Melbourne cohort. You can see followed from 10 years to 50 years here. And you can see that the lung function trajectories just follow. They're set in childhood. So the European Community Respiratory Health Survey, again, lung function trajectories followed through adulthood. And the major determinant of this lower lung function trajectory was childhood disadvantage as measured by LRTI in childhood or smoke exposure in childhood. We also know, and this is in a huge study of over 126,000 adults followed in many countries, that the major predictor of premature mortality is reduction in FEV1, is a decline in lung function, more so than tobacco use, hypertension, cardiovascular disease. Measurement of lung function is a measure of general health. It's a measure of underlying susceptibility. And so I think with this early data, that in fact early life lower respiratory tract infection is probably directly impacting on lung function, setting children on a trajectory for impaired lung health, to COPD, to asthma, and even to premature mortality. I think the imperative to prevent RSV-LRTI is huge. If we really want to quantitate these, the impact on recurrent wheeze or asthma of the interventions, we're going to need huge sample size, as this was a paper that was previously published. But I think in post-licensure settings, we probably do have an opportunity to more accurately measure the impact on these outcomes. So let me leave you with some key messages. RSV-LRTI is strongly associated with recurrent wheeze and asthma. It is modified by host environmental variables, and it's less when accounting for genetic susceptibility. RSV-LRTI appears to be associated with recurrent LRTI, and all-cause LRTI impairs lung function, non-specific to RSV. There's good animal and in vitro evidence for mechanisms linking this impairment through alteration of immunological pathways. And I think the question of the impact of the new RSV preventive interventions on more long-term disease, wheezing, asthma, COPD, and even premature mortality is a question that is really unanswered, but that post-licensure studies may help with. And it will be important to these studies to collect the other outcomes that I've alluded to. Thank you very much. Just to acknowledge my incredible Drakenstein team, students, collaborators, the Gates Foundation, who were the key funders of Drakenstein, and of course, all our mothers, children, and participants. Thank you.
Thanks, Sarah. That was beautiful. And we're ready for questions. Yeah, I know, but I think that since we have an hour break, we will steal 7 minutes from that hour. So at least
Right here.
talk loudly. You can do that.
I speak loud. One aspect that I was striking, I think realized, I heard about many times about the timing of the first LRTI. Sorry. Thank you so much. First, I was going to acknowledge that it was a fantastic talk. Thank you. The timing of the first LRTI, I did not realize until this time that when you presented this, I heard you many times, how that critical that is in the outcomes, right? Can you comment a little bit on that?
Yeah, I think thanks Octavia for raising that. That is a critical point. And most of the data suggests that the timing is absolutely critical in terms of the association with subsequent recurrent wheezing or asthma with earlier life, so under 1 year of age, most strongly associated with the development of subsequent morbidity. And of course, that's also related to severity, right? We know that the peak period for hospitalization for RSV is under 6 months of age, and we know now that severity is associated, there's a dose-dependent effect, right? That the more severe disease is associated with. So that's even more important in terms of the strategy of preventive interventions that we have. If we can prevent that early life LRTI, it looks like we may ameliorate this association.
No, I was so intrigued because the work that Asun and I have been trying to understand about the innate immune response to RSV is totally different before or after 6 months, and it was amazing to see how that has this long-term implication. Yeah,
that's really interesting, yeah.
So, thanks. We will go to the next because otherwise Laila will kill me. So, please, Sanjuti.
Hello everyone. It is such a pleasure to be here. And I said yesterday that this is my first RSV meeting and I'm thoroughly enjoying it. So I am Shejuti and I work at the Child Health Research Foundation in Bangladesh. So I'm going to share my story about RSV infections in Bangladesh. The red dot there is not Bangladesh, Bhutan. I know this is the last talk of the session. This is Bangladesh, so pay attention. So CHRF's RSV work really started with the ANISA study, which was a large study that wanted to look at what are the main causes of infections in neonates. So this was a study that was conducted in 3 different countries across 5 sites. We enrolled more than 60,000 babies that were born, followed them up for 2 months, and tested for 15 different bacteria and 13 different viruses. And as you will see over here, that RSV, shown over here, really stood out. So this told us that RSV is indeed the predominant cause of infections in neonates. So here I'm showing you a quick timeline of the work that we have been conducting. So around the end of 2017, we started a small-scale RSV study in the largest pediatric hospital of the country, and I'll keep on coming back to this hospital. So the bars are the number of children being enrolled, and in red are the RSV-positive cases we're detecting. In addition to that, we just started a smaller study in a community where we know that most children with RSV do not access care in the hospital. So we have a group of community health workers who go to every household with an under 2 children in this case and collect samples in the community. However, I'm not going to talk about either of those studies today. Rather, I'll talk about a very comprehensive study that we did in 2019 to look at the hospital burden of RSV infections, and this was funded by the Bill and Melinda Gates Foundation. So why did we want to look at the burden of RSV on hospitals? Because what we see is this dilemma in policymakers. Despite the high prevalence of disease, it is considered not a very serious infection. And the policymakers understandably have a question, and they ask us often, why introduce a vaccine that has low mortality rates? Well, it's understandable again because many countries, Bangladesh included in them, is about to graduate to middle-income countries, so we are gradually going to lose Gavi support. We have already introduced a lot of vaccines, and some of the vaccines we have to pay for in the future, and they're expensive. And we have several competing priorities. Competing priorities not only between diseases, but our governments also have to decide, pay for a new vaccine or send girls to school. So we have to be very, very careful with the data we are collecting and how we present our data to our policymakers. We believe that it's very, very important to prevent RSV infections because an RSV vaccine will not only reduce morbidity due to RSV infections and mortality due to RSV infections, but it will also reduce burden on the health system and thus prevent mortality due to other communicable and non-communicable diseases that are non-RSV diseases. And why did we want to do this study? This is, again, an example from the same hospital, the largest pediatric hospital. This is data from 2019. We'll come back to this. But this basically shows the number of admissions and the causes of admissions in this hospital. So it's a large hospital. Every year, we admit about 23 or 24,000 patients, all children. And you can see all the diagnoses over here. But every year, we also refuse about 20% of the children seeking admission because we do not have empty beds. So these patients come in, they need hospital admission, but we are saying, no, we do not have space in the hospital. So they refuse admission due to lack of beds. And this is not surprising. This is not only the scenario of our hospital, this is quite common actually. And it's not surprising because, we have limited resources, and we have 10 times less bed than, let's say, the US. So we asked the question, or we hypothesized, that these children who are refused, babies who are refused, are more vulnerable to death than babies or children who are admitted. And we asked the question for this study is, if we were to prevent RSV infections, would we empty up beds, and thus would we refuse fewer cases and prevent additional deaths? So we designed the study with these objectives in mind. We wanted to understand or estimate the burden of RSV infections in children hospitalized in this hospital. We wanted to estimate the burden of infections on bed occupancy in this hospital, and also determine, this is not RSV specific, but determine the impact of admission refusal on health of these children who are refused. So again, now you know where Bangladesh is. This is the shape of Bangladesh, and we work right over here in the middle of the country. This is where the largest hospital is, called Bangladesh Shishu Hospital and Institute, previously known as Dhaka Shishu Hospital. About 665 beds, and the way this hospital works is beds are always full, so when patients need admission coming in, it's basically a first come, first serve, which reduces bias in decision making of who is going to get admitted and who is going to get refused. So this is kind of the design of the study. On a particular, on any given day, some families will come in with their children and they will need admission. About 80% of them will get admission on that day, and 20% of them will be refused admission because we just don't have enough beds. Beds have already been filled up. So for children who are admitted, we visit every child every day, and we enroll them in our study if they have any signs and symptoms that meet the inclusion criteria. For our RSV study, which is the WHO criteria, we collect a sample and then we test for qPCR immediately, test for RSV through qPCR immediately. Then in parallel was our refusal study, where it was a very difficult study to do, but every time a mother or a dad was refused admission, we had a team who would go talk to the family, collect information for them, and give them a call in 2 weeks, then in 3 months, asking how the child was doing after they were refused admission. So first, let's focus on the hospital part of the study. So the total number of under 5 children, so in this study we only focused on under 5, that who were admitted in 2019 was about 20,000. 36% of them were were enrolled in our study. As you saw in my previous pictures, really respiratory infection is the main cause of seeking hospitalization. Of them, we were able to collect specimens from 86%, and 21% were positive for RSV. This is an epi curve of what RSV looked like. So we started right at the end of one peak in winter and then quickly moved on to another peak in the summer. So this is just numbers, but what I'm showing you over here is basically the proportion of RSV infections in each day of all admissions. And what you will notice is that, during peak season, 20 to 30% of all beds were taken up by RSV cases. When we look at age distribution, mean age was 29, median age was 14 weeks. And 48% of all cases were in the first 3 months of life, 65% in the first 6 months of life. We also looked at a length of stay. So mean stay, average stay was 6.5 days about, but median stay was 5 days. So they're really not only getting hospitalized, they're staying at the hospital for a long time, occupying the beds. Now, let's look at the other side, right? Let's look at what's happening to children who refuse admission. Again, this is not specifically looking at RSV cases. This is looking at children, babies who are refused admission because there are no beds. So first, we recorded every child, under 5 child, who were refused. We randomly selected children for follow-up. We were able to follow up through the 3 months, a little over 3,000 children, and these were all phone follow-up. But of course, we need a comparison. We cannot only look at children who were refused admission, we have to compare all of our findings to children who were admitted. So we also randomly selected children who were admitted, nothing to do with RSV, who were admitted and then followed up a little over 2,000 children over the next 3 months. When we started the study, we really were not sure if we will find drastic differences in mortality, so we had all these plans of doing morbidity analysis, etc. But the first thing we did is look at mortality. So over here, I'm showing you the proportion of death first in the children who were admitted. So 14-day mortality for children who were admitted was about 9%. So 9% of the children admitted die. Then by 3 months, about 14% of the children who are admitted die. So this is what's happening in children who receive care. Very different in children who are refused. And for us, this was very striking, although we designed the study for this. 14-day mortality in children who are refused admission because of lack of beds was 15%. And then children who were refused admission by 90 days, this mortality was over 19%. But, we ask questions. Is it, driven by really refusal, or are there confounders like age, diagnosis, sex, etc.? So this is odds ratio, so odds ratio of mortality if you are refused, so in comparison to if you're admitted. And we said that, the odds ratio of mortality in the unadjusted one is 1.5. Then we stratified by age. And what we found here that really mortality was highest, significantly higher in children or babies in their first month of life. So, neonates coming in were most vulnerable. We also looked by stratifying by diagnosis. And here we see, spelling mistakes. Here we see concordant with this data that the first month of life is the most crucial. That's when they need most care. Babies coming in with birth asphyxia, preterm low birth weight are, again, most likely to die within 90 days. We also looked at stratified by sex, and males are more vulnerable, and this is basically adjusted for everything, adjusted for sex, diagnosis, and age. So still, the odds ratio is much higher. So this brings us back to the question that we started with. We know there will be direct impact of the vaccines. We know that there are deaths in RSV cases too, but what will be the indirect impact of this vaccine, right? How many deaths will be averted that in cases that are non-RSV? So for this, we did a simulation. We did a Monte Carlo simulation, and we took all of these parameters into consideration. We looked at, from the observed data that we found, the number of beds. We knew the number of cases required admissions per day. So not only children who are admitted, but both refused and admitted. So number of families or children seeking admission, length of stay. We observed a mortality among admitted and refused, and this includes RSV cases. For our vaccine efficacy parameter, we used the data from the press release from Pfizer in November 2022, and of course, we saw more detailed data yesterday. And as output, we looked at refusals, bed days, and mortality in baseline versus vaccine. And so this is the data that we basically have now. So this is all simulated. So our model says that on any given year, and this matches our observed data too, about 30,000 total children need hospitalization when there is no vaccine. With a vaccine like Pfizer, we would be reducing the need for hospitalization by 704. So requirement for hospitalization will be lower, provided there is high coverage in the vaccine uptake. Then we looked at total bed days for RSV admissions. This will decrease. Without a vaccine right now, total bed days taken up by RSV cases is over 8,000, but this is going to decrease to less than 4,000 overall, and this is going to free up 4,500 bed days in just one hospital. Again, this is all like a case study, right? But just one hospital. So number of children refused will decrease because now with this extra bed days, we can admit more children. So in baseline, we were refusing a little over 4,600 around children every year, but this will decrease because now we can accommodate more children and really will be refusing 700 less children every year. And finally, so what does it mean for deaths? Among admitted and refused, we will be averting 81 deaths per year just in one hospital with an RSV vaccine. Again, just one hospital in Dhaka. So in summary, I have told you that there is a fierce competition for beds. I've shown you an example of one hospital, but this is true for all public hospitals in the country. 1 in 5 patients are refused admission because there are no beds available. This is throughout the year. And I talked about RSV today, but we have very high burden of infections. Every year we have outbreaks of dengue, we have a high burden of typhoid. So there are all of these diseases, and then of course there is RSV, and on average, 6% of all admissions is RSV. During peak season, 20 to 30% of all beds are occupied by RSV cases, and each RSV case occupies beds for about 5 days, and this can lead to refusal of other communicable and non-communicable diseases that I showed before, and preventing RSV cases could free up about 4,500 bed days, admitting about 700 more cases, and this could avert 81 deaths per year, and this would be mostly averting deaths in babies who need admission in the first month of life with birth asphyxia or preterm low birth weight. I'm very privileged to be able to join this meeting and speak, but of course with me is this amazing team. We are over 300 people at the Child Health Research Foundation, and this was a very, very hard project, as I said. It's really hard to go talk to parents and ask for their phone number after they have been refused admission. So all our health workers, the first few months, they just cried every day. But everyone is still working with us, so they didn't leave us after the project ended. A lot of the simulation work, the statistical work that I showed today were done by Shudipto, who is a PhD candidate at Harvard. And if you have questions about all of that, I'm happy to share his phone number. Just don't tell him I gave it to you. Thank you.
This was really, really amazing. And you have to put a lot of assumptions there in order to do this calculation. But the basic assumption is probably based on the vaccination coverage. What is the vaccination coverage in your area, and is it something that has to be improved?
Very good question. I think we were very confident when we were rolling out this study that it will be representative of what will happen post-vaccine, because Bangladesh is an example case of vaccines. We have more than 95% coverage throughout the country. There are places where it's like 99%. So that is something we're not worried about.
Thanks very much. It was a great presentation. I mean, another assumption in your presentation is that if you free up those beds, if you prevent those cases, what will happen is the beds will be freed up, right? It could be that they close the wards or reduce the capacity in the hospitals, etc. And I wondered, I mean, your presentation reminded me of the experience we had in South Africa with rotavirus vaccine, where with the rota vaccine, we used to have these diarrhea sleepover wards, and they were really closed after the vaccine was introduced. You know, we didn't need, and I think the potential is the same with RSV, as you say, and I wondered if you'd ever look back I mean, have there been past vaccine experiences where you could look back and really see whether, if you reduce the disease, it does actually have this impact in terms of reducing the turnaways, you know, or validating that assumption?
Reducing wards and number of beds post-vaccine?
Well, that if you reduce burden of one disease, that will lead to opening up space and less numbers of children turned away.
Yeah. So no, we don't have direct experience of working or collecting data like this for other diseases in the past. However, we have worked on hip vaccine, and that was introduced in 2009, and then we worked on the pneumococcal vaccine in 2015. I think what's really important to understand is we are decreasing burden of certain diseases, but at the same time, the burden of overall diseases is so high that I think we have to constantly work towards emptying up more beds, and population is also increasing. Bed numbers also in this hospital constantly increase to be able to accommodate more and more patients. But something that I should also say is that here I'm advocating for RSV vaccine, but there's a lot more needs to be done. We also need to work on our health infrastructure, increasing number of beds, ensuring that there are more community clinics, etc.
Last question.
Thank you. My name is Max Yerle from ICOSAVAX. Lovely presentation. I'm wondering, I mean, I know that you focus your presentation on RSV for pediatrics, but I wonder if you have something to share about the burden of illness of RSV in older adults, and hospitalizations are associated with RSV in that population.
Right. The answer I want to give you is I only like children.
Okay.
No, all our surveillance studies are focused on children at the moment, so we don't have any data on adults.
Okay, thank you.
Okay, so thank you. We are closing this session. I believe, I cannot speak for myself, but at least the other three talks were fascinating, and I think we are starting to enlarge our view of RS virus into much more than just RS virus. So thank you for the speakers and for the audience.
depois se calhar o mesmo pode não ter capacidade para receber aquilo tudo. Não sei, logo se vê. Aqui acho que não vai usar eu. Passo ao slide, estás a ver? O laser não sei porquê. No Keynote não parece que funciona.
20 anni ha pubblicato un solo lavoro su riviste non a pagamento, sempre come quinto, sesto, settimo nome. Io ho 5 New England, 5 Lancet, 5 JAMA, ho preso 6 o 7 milioni di euro dalla comunità europea, dall'AIFA, i finanziamenti, sono nel board di tutte le società mondiali, eccetera. 5 anni che sono direttore di un dipartimento materno infantile a Biella, che è un ospedale universitario.
E non...
No, perché io non sono delle loro... E allora non c'è alternativa, perché tanto a 60 anni, perché mi metto a chiedere scusa per io continuo a farmi le mie cose, vado avanti con la giustizia, se c'è giustizia e se si può fare bene, se no a un certo punto andrò lì, prenderò una targhetta, il badge, dirò mettetelo su per quel posto.
No, ma volentieri adesso magari ti do il suo numero.
Io non vorrei essere invasivo o anche non applicato.
No, assolutamente.
Se magari
può darti un'idea anche solo di quali sono le prospettive, come la vede. Sì, certo, la sento ogni giorno.
Se puoi buttarmi lì che hai conosciuto me, che sono abbastanza di peso, che ha questa grana in questo momento, se non è inappropriato, non è disturbo, se posso fare una chiacchierata su quali prospettive ci possono essere, sarebbe molto. Se tuo papà è impegnato o lo trovi inappropriato,
assolutamente, ma lui di solito questi consigli lo fa spessissimo. Che mi lasci tu un numero così.
Allora ti faccio una chiamata.
Perfetto.
Se mi dici il tuo ti faccio una chiamata.
39 59 27 578. We should get started, yeah. 10 minuti.
Ok, è arrivata.
L'ho ricevuta.
Hai questo qua?
No.
No, aspetta.
Sì, no, dovrebbe essere proprio fisso.
Adesso.
Se no tanto ce lo ricambiamo.
Ora, se non fai pure 338 0039. No, scusami, 0039 l'Italia. Prima di 338
per aggiungo.
90 125 90.
Ciao, ti scrivo su WhatsApp.
Sì. Eccolo qua, questo qua Svizzera. Ah, per quello.
Tanto comunque io
perché non era 339, era...
Cioè no, in realtà il mio WhatsApp, io ho entrambi su queste qua la doppia SIM, però ti scrivo anche su WhatsApp.
Sì. Senti, iniziamo.
Sì.
Good morning to everyone. Please take your place. We left some minutes, some additional minutes to let you enjoy your coffee, and we get started now with this final session of the morning, focusing on clinical interventions and global use against RSV. I am Paolo Manzoni. I have the pleasure to chair this session together with not Pablo Sanchez, as you can understand. This is not Pablo. Pablo, unfortunately, is stuck in the USA for a meeting with the CDC. He's apologizing very deeply for being not able to join us. And so, luckily, Dr. Octavia Prunas from Basel in Switzerland volunteered to co-chair the session with me, and I have the pleasure to let her introduce herself and focus on the main topics of this session.
Good morning, everyone, and welcome to this session. I'm Ottavia Prunas. I'm a postdoctoral associate at Swiss Tropical and Public Health Institute. So today's session will focus on deepening some practical aspects about implementation. We'll have different talks ranging from monoclonal antibodies to other aspects like interference with the immunological and neurological synapses, which are particularly important to have a better understanding of vaccine targets. And finally, there will be some discussion around RSV vaccines in adults.
I think that we can proceed with no further delays because we are already in time, and so it's my pleasure to invite Octavio Ramilo, a good friend and a board member of Resvinet, being no more affiliated with the Nationwide Children's Hospital, but with the St. Jude Children's Research Hospital in Memphis, Tennessee. Octavio, please, the floor is yours. Thank you.
Thank you so much, Paolo. Thank you for the opportunity to the organizing committee for presenting our perspective. This is going to be a combination of data and opinions. So I know that I'm sure there will be some discussions afterwards. And I was fortunate to be at the end because I could see what the people were presenting, and I took advantage of some of that data. These are my disclosures. As you know, and Paolo mentioned, I'm a board member of Resvinet. This is the summary of the topics that I would like to cover this morning. I want to go back and think why we decided to do passive immunization, why we think maternal vaccines or monoclonals are a good option for these young children, why we don't think on giving as traditionally we do with vaccinations at 2 months. I would like to talk about the innate immunity of RSV and the antibody responses in infants that we have studied in our group. And that's what I was asking Heather a minute ago about the timing of the infection in the long-term implications for repeated LRTI. I touched in a couple of data that was presented already. I did not know how much to touch about that, but it was presented. But maybe we can comment on a couple of topics. And then I will try to bring the picture for all of us to think, what are the implications if we want to start a new program like universal administration of monoclonal antibodies? I will separate 2 aspects. One aspect that is more the clinical, immunologic, virologic, and the other one more, if you want, policy, logistics and regulatory aspects. And then, this is totally my personal opinion, what is next? Last night, some of our colleagues were talking, okay, this is it. RSV is conquered. We should move on to something else. I think in the other way around. This is just the beginning. And this is the beginning of a road to, our colleagues, our scientists from the companies have generated and produced these amazing vaccines and monoclonals. It's up to us, the clinician, to figure out the best way to implement to reach as many babies as we can. So why we start thinking about passive immunization in RSV? Let me talk about the innate immune response for RSV. Our group has been focused on using transcriptome analysis, looking at mRNA as the best target, because we think mRNA allows us to summarize the pathogenesis of the disease and to connect the pathogenesis with the clinical phenotype. So there are many factors that allow the virus in the context of individual patient to cause the infection and stimulate the immune system. But somehow, if instead of looking at the genomic, if we look at the message, so instead of looking at the library, we look at the book that is being opened and is being read, we are more likely to understand the pathogenesis. And not only that, mRNA has correlated with disease manifestations. This is the first study that Dr. Mejias and I did in Dallas, and we found for the first time that when we look at the transcriptome in the blood, she shows some data in the mucosa of a junior colleague, Becca Glowinski, but you see how strong that signal is. The yellow are the healthy controls, and then you see the kids with RSV with a very suppression of some genes and activation of others. It's a very strong signal, and it's very consistent. Not only that, we have been able to correlate the disease severity with the change in the transcriptome. If you compare mild, versus moderate versus severe. You see that the number of genes in red that are activated or suppressed increase, so the immune dysregulation is worse. We can quantitate this using a genomic score that we call MDTH, and as you can see, as the kids are sicker clinically, they also have a different profile that is statistically significant. So the immune system is so smart that it can tell that the kid has RSV, but also the severity. And indeed, when ASUM correlate the genomic score with the clinical score, that means the breathing, the respiratory rate, the O2 sats, it correlates clearly between the genomic score that we call molecular distance to health and the clinical severity score. And when we measure that score on the day of hospitalization, it correlates with both the length of hospitalization and the days of oxygen. So really, if we learn how to read the immune system, there's a lot of information that we can help us understanding pathogenesis, response to infections. Obviously, this is another great tool to study vaccination. But what it took us a while is to understand the impact of age. Why is that? Because the majority of the children that we study in the hospital are very young, 2, 3, 4, 5 months. And the majority of the children that we see as outpatients tend to be older, 6, 7 months. So it took us 3 or 4 years to have enough children in these cohorts to measure the profile in the first 6 months of life versus the 6 to 24 months, and in green, hospitalized with severe RSV, and in pink, children managed as outpatient. So the data are really interesting because this is the way we present the gene expression data. We call this an spider. And you can see that here we have the different elements of the genes of the different components of the immune system. We can compare the innate immune response, the inflammatory, and the antiviral response. As you can see, among the inpatients in green, there's a lot of activation of the genes of inflammation and a bit of monocytes. And there was no difference in the interferon antiviral response between the outpatients and the inpatients. However, when we look at the older children, the picture changes dramatically, and we were really surprised to see this. Look, focusing on the green, the outpatients, again, a lot of activation of inflammation genes and neutrophil genes. Now, when we look at the outpatients, however, you see that for the first time, high activation of interferon genes. So only after 6 months, the immune system mounts a good response with interferon to RSV. That's why RSV is perfectly designed to hurt, to infect, and cause disease in this younger population. Indeed, when we also want to look at the maternal antibody responses, because the interferon has 2 main roles. One, controls the viral infection and modulates the acute disease severity, but also has a secondary step, which is activating the B cells to make antibodies. So the data is also very similar. This is data on day of hospitalization, and the most abundant antibodies are pre-F. They are maternal antibodies, and you can see that they drop really, really fast, That's why natural infection is not so protective. What happened when we look at the baby's ability to mount antibodies? Here we have almost 200 kids, and you can see we divided by age groups, very small groups to be able to capture the difference, and we have 3 time points. On blue, here, you have acute, so these are maternal, 1 month later, so the antibodies make at the baby originally, and see if they last up until 6 months. You see that in the first few months of life, the response is very, very weak. We can begin to see something here, but it's only after 5 months, 6 months, that we can see a nice response 1 month, and that antibodies can persist until 6 months. Obviously, this is natural infection, but if the interferon response is so immature, and the baby's ability to mount a good antibody response is so weak, it makes sense that we think about using monoclonal antibodies or maternal vaccination, right, to give passive immunization in this age group. That's why I'm a little bit skeptical that the strategy is to immunize at 2 months of age, which is, what we always think in terms of vaccination is not going to work. Okay, the history of monoclonals is quite remarkable. It's been 20, 25 years, right? Pali is a mouse monoclonal and then humanized. Mota, that increased the potency because they mutate the FAB region, is also humanized On the other hand, the new generation of prolonged half-life monoclonals are human monoclonals, and you know the two main ones, nirsevimab already approved, lesovimab is the second one. They bind to site 0 or site 4, and they also have the mutation, the prolonged half-life. So it's a tremendous improvement, right? We think, we see the data from our colleagues and presenting this yesterday on the two monoclonals, and I think, well, but it's important to keep the perspective on how this all started. We have seen this. Dr. Dagan presented the data on nirsevimab. It's remarkable, the more I look at this slide, that when we look at the outcomes, right, the different outcomes, and we look at the medically attended LRTI, the medically attended LRTI with hospitalization, and the very severe one, the efficacy is the same. That's a very important point, that we need to understand how it's so effective against all outcomes. And when the company was asked by some of the committees to put together both the 2B and the MELODY trial, and you see the data, is nice to see the curve of the efficacy. Now, yesterday we have the nice data on the PK of lesovimab coming now, really, really encouraging to see this. We also saw, and the blue highlight is my edits to the original slide, and I have to thank friends and colleagues from Sanofi and Merck for sharing all the slides with me. I put the percentage because it's important to keep the data easier for us to understand, and this is so preliminary, but at the same time, really, really potent activity, which is good to have two molecules confirming the same benefit, right? This proves the value of this strategy. And there was a poster by my good friends of Merck shared this with me, that there is new data that lesovimab really gets very nicely into the nasal mucosa. This is data from their phase 1 in adults, that they see that the lesovimab gets really very nicely in the nasal mucosa. And I think that's an important topic. I was looking last night and this morning to try to find the data on nirsevimab. I could not find it. Maybe our friends from AstraZeneca or Sanofi can comment on that. But this is very important. We need to focus on the mucosa. We have that discussion. We need to understand, because that's the beginning of the infection. Now, 5 years ago, I was asked to work at a symposium on monoclonals at ESPID. And this is the slide that I make at that time. And we thought about, we are reinventing the role of monoclonal antibodies for prevention of RSV. Why is that? Because we all grew up with PALI, right? And full disclosure, I was involved from phase 2 on PALI forever, right? So I have a little bit of perception of the value of monoclonals from day one. We focus on the very high-risk kids, and we need to give them 5 doses. Now, at that time was called MEDI 8897, now called nirsevimab. The idea was 1 dose, the whole birth cohort. And I want to go into this. What does it mean, whether it's with nirsevimab or lesovimab, if we want to have and to cover the whole birth cohort? I would like to comment on 2 particular aspects. One is the safety and immunologic concerns, and then my very biased perspective about the logistic and regulatory challenge that we all face. So what are the potential safety concerns? We heard during the COVID that because of the lack of circulation of RSV, and we see this enhanced disease, older children, maybe more severe, if this is going to happen, say, well, Octavio, you guys are thinking that you can prevent RSV in the first year of life with the monoclonals, with the maternal vaccines. What's going to happen? Maybe on the second year it's going to be terrible. Well, I don't think that's going to happen, and let me argue why. This is the original data that AstraZeneca and Sanofi have generated. I think Dr. Dagan presented this in the meeting in last fall in Belfast, right? The data suggests that the second season there is not an increase in RSV disease. Obviously, it's not the perfect, you can ask, well, it's only 1 time, I agree. It's only 1 season with this abnormal. But also, there was not an increase in LRTI caused by other viruses, which is even more reassuring. So there is no potential of effect. And why is that? Well, there is an immunologic reason. the monoclonal antibodies do not cause sterilizing immunity, and I think the maternal vaccine is going to be the same. They are going to not prevent infection, but they are going to modulate the infection and make it so mild that the immune system will still recognize the virus and will have a normal immune response. Not normal, but enough to build them. So that's the big issue that the people have been asking. Are you going to change the whole immune development and exposure to RSV? This is very interesting data who has been given to me by Sanofi colleagues, and you can see the data on the monoclonal and the neutralizing antibody in both the phase 2b and the MELODY trial. Here we look at the placebo group. The placebo group that did not get infected in the open, and the placebo group that got infected with the blue solid. And you can see that the infection increased a little bit of the neutralizing antibodies, but not much. What happened when we look at the group that got treated with nirsevimab? You see whether you have infection with RSV in the solid or not. The titers are really high, way, way higher than when you see after natural infection. And the titers are so high that even after you get these babies that got infected, you didn't see an increase in the neutralized antibody. There is data that I've seen, and I don't know where, I could not find the slide or the poster, that during this study, the team at AstraZeneca looked at the production of antibodies against other targets, like post-F or G, and they also make those antibodies. That means, and this is very, very important, the monoclonal antibodies do not cause sterilizing immunity. The kids are going to still get to see RSV, so they are not going to be naive, and this is very important in terms of safety for what's going to happen in the second or third year of life. So, resistance. Tony made a really good point, but every time I see this slide, I remember and why we need to be very vigilant. This is the subtamumab trial. There was no efficacy. This is the placebo in green, and the 2 doses in red and blue, no efficacy. But it was very striking that there was a nice efficacy against RSV-A, but no efficacy on RSV-B, and we all know now that the virus was totally resistant to RSV-B. Important to remember that these mutations occur spontaneously. There was no pressure, there was not immunologic pressure, there was nothing. And this happened because the virus mutated. And we need to be aware of that. So I think looking at the data that Tony showed yesterday and the informed data is really important. So last ID week, the team at AstraZeneca summarized their recent experience looking at the variants that may emerge against the sites that may be critical for nirsevimab resistance, right? So they look at the data on the phase 2b and the MELODY trial, right? And in this very nice graph, this is the binding site. And you see that in RSV-A, they did not see many important frequency of mutations. But RSV-B, again, is when the mutations show up. And you see, when they look at mutations with more than 5% frequency, there was only one in RSV-A, and it was out of the binding site, so it should not affect the efficacy of the monoclonal. But in RSV-B, there were 10 unique substitutions, and 2 were within the binding site, especially the 26M and the Q2R9. But look at that mutations seem to be occurring commonly in the circulating strains, but something totally unexpected, that the mutation, the Q2099, increased the susceptibility of the virus to nirsevimab. Very cool, right? That here, instead of being a problem, improves the susceptibility. And this is the bottom line of the data that they have so far, and I think I'm really happy that we develop efforts to do this. You can see this is the summary of they presented, and again, I got the slides downloaded from the webpage, so if I make a mistake, please come here and tell me. So there are 2 infants in the phase 2b study that have resistance-associated mutations, the 164T and the K68B, and 1 single one. And you see these guys here, these 2, they are really resistant, right? The rest, really, really low, nothing with impact on the susceptibility to the monoclonal. Again, we need to be vigilant. It's nice to see on the blue is the RSVB with that 209 and that increased susceptibility. So a lot of work to be done. I think we need to continue to do this. I applaud the team for continuing and doing this. Now, what is our ultimate goal? We've been talking all 3 days to protect all infants against RSV. For a minute, we are going to hold on the elderly. I'm biased, I'm a pediatrician. This is the goal, right? What does it mean? It means that we want to target the birth cohort. Do you know what is the birth cohort? This is the birth cohort. When we talk about the birth cohort in the US, it's 4 million. When we talk in Europe, it's 5 million. When we get in China, it's 17 million. When in India, it's 25 million. And the world is 140 million. That means that every year, 140 million babies are born. And that's what we want to do. So the people ask me, Octavio, what do you think? What is better, the monoclonals or the maternal vaccine? Say, what do we think? We need everything. We need to reach all these babies. If we can have 3 more vaccines and 5 monoclonals, can we make enough vaccine and monoclonal to reach this population? That's the goal. So this is the way I see the challenges, moving from the clinical, immunology, virology to the price. So what are the things that are going to decide how these monoclonals are implemented? Number 1, the cost, which is a little bit connected with the price, but not exactly. So I hope all my friends from AstraZeneca, Sanofi, and Merck convince their bosses to, because I know there is nothing up to do with you, that we keep that low. Second, it's not just how much they cost, but how we finance that purchase, right? Some countries have national healthcare systems that we can make decisions that are more uniform, but even in countries like Spain, different regions make different decisions about how they use the budget. Or in Canada, I think each province makes the decisions. In the US, it's even more complicated because we have a number of different payers, right? There's commercial payers, and then we have the Vaccines for Children program that the CDC runs. So the way we define these monoclonal vaccines is going to affect the funding available mechanisms. Is going to be Gavi step into this? How are we going to do this? Very important discussions, very important discussions. We continue to have the need for local data. We know that we cannot predict RSV. We need to be humble and knowing that each region might be different. We learn a lot of what happened with COVID. It was reassuring that Dan showed us yesterday the models that tend to think that things are going back to normal. Where are we going to give the monoclonal? In the hospital, in the clinic, some in the hospital. We are going to have clinics for vaccines and monoclonals, and how we define the target. Where is the best groups that are going to benefit from the strategy? So, and the monoclonals are not going to be alone because the vaccines are going to be at the same time. So we need to put this into consideration on how we examine and why we need more data. So this is what I would like to see us doing. What are the proposed analysis we need to continue to do as we start this new era? And again, this is very personal. First, we need to look at outcomes. And we need to collect hard data on mortality, on the places that you implement an intervention and there is mortality. We need to have that data. And we need to have data on hospitalizations. I'm convinced that Malri is not mild. Malri with RSV gives you a lot of morbidity and a lot of long-term consequences. But to convince society that they keep financing what we want to do to prevent RSV, we need that hard data, mortality and hospitalizations. Well, Heather did such a master presentation of the pulmonary morbidity, because it's not just wheezing, it's this recurring LRTI. And bacterial superinfections, Ron mentioned that, is very critical. I think this was a little bit the dogma, and we need to look at that outcome as well. We need to continue to look at the seasonality, the changes in epidemiology. We need I'm so happy that WHO is having such a big effort. We need to have that. We need to look at sequence variation. Come on. I'm thinking that 5 years from now, the same way that we look at antibiograms to decide which antibiotic we choose, we'll have sequence data to look at the different viruses consistently. And we need to look at cross age groups. So what else we need? Because what else we need? Do we think that the current vaccines and monoclonals and maternal and elderly are going to be sufficient to have herd immunity in the population? I doubt it. This is the group that I really worry, the older infants, the ones who are 8, 9, 10 months old and the kids under 5. We still don't have a platform from them. We need to work. What about adults? It was really good knowledge for me to learn that maybe if you are 45 but you have cardiac disease, you may be a good target for an RSV vaccine, right? So a lot of work needs to be done there. So in summary, I hope I convince you that the young infants demonstrate inadequate innate immunity and antibody capacity, and the capacity to make good antibodies against natural RSV infections, that extended half-life monoclonals really represent an amazing and very attractive strategy that we need to address the safety, virologic, and immunologic concerns, as well as the logistics, policy, funding challenges. We need studies now to address the real-life impact of RSV prevention in both acute and long-term outcomes. We need to monitor the seasonality, the sequence variation, and the impact of different age groups. And we need to have new vaccine platforms to address the older infants and young children. Thank you very much.
Thank you. Thank you, Octavio. For sake of time, we'll keep the questions for the end of the session. So I will invite now, it's my pleasure, Dr. Alexis Kalerkis. He's a ID specialist and a researcher from the Pontificia Universidad Católica de Chile de Santiago in Chile. And please, the floor is yours about this very interesting talk.
Thank you very much for the invitation to organizers. And it's a pleasure to be here. It's been a very exciting meeting the past few days. So I will, these are my disclosure. Most of the funding that we use in the lab has to do with competitive funding from local and international programs. And I will tell you today about the way we think RSV can interfere with the initiation of the immune response. So as you know, T cells and dendritic cells are required for the activation of the immune response against bacteria and viruses. And we found we are currently working on this as well, that the RSV, this very major pathogen, which in Chile is a pretty major, used to be seasonal, but now with COVID, we've been discussing here, is moving. It's a pretty severe pathogen. We found some time ago that this virus is able to prevent the activation of T cells, naive CD4 cells, by a mechanism that we described based on the interference with the activation of the T cells by the immunological synapse. And it's shown here in these movies. In red, you see dendritic cells, and in green, T cells. You will see that on the left, uninfected cells are able to establish these synapse structures that are not seen when the cells are infected with RSV. So it's about 70% inhibition of synapse assembly between dendritic cells and T cells. So we thought that maybe a protein from the virus could go to the membrane and interfere with this process. And as we heard on this meeting, the virus has 10 genes that encode for 11 proteins, so we could test one by one. And in different systems, I'll show you one experiment where we used planar lipid bilayers, and we added MAC plus peptide and additional molecules, and then tested one by one the RSV proteins. We found that, as shown here, in the absence of viral proteins, you see clustering of additional molecules and T cell receptors. This is a protein from RSV called M2 that does not really affect the synapse. And N, the nucleocapsid, is totally able to prevent the synapse assembly between the cell. And this is shown better in these movies. Again, you see live cells and the overlay between T cell receptor and MAC. And on the left, on the controls, each of these yellow dots are synapses between the live T cells and the antigen. And here on the right, you have the same assay, but only with the protein only with the N protein, nucleocapsid protein from RSV. There are way significantly less synapse assembly. So we looked whether the protein was on the membrane, and it is, as is found for F and G. We can also find N on the membrane of infected epithelial and dendritic cells. And this is also shown here by flow cytometry. You have F, G, as you expect on the membrane, but we also saw N on the membrane of these cells. So we thought that the nucleoprotein could be an interesting candidate to tackle in terms of antibody development and vaccine development. So we have an antibody that humanized for the nucleoprotein that we're trying to push forward as a treatment. But I will tell you today about a vaccine that we made for RSV based on the nucleocapsid. And we decided to use the BCG, which is the vaccine for tuberculosis. And we published this several years ago about the vaccine, the mechanism behind the protection. It's a T-cell mediated immunity that enhances antibody production upon infection. This is all published data. But we decided to move forward with BCG because, and here are the reasons, but I just wanted to point out something that Octavio just mentioned, the importance of inducing proper Th immunity in young infants. So we went all the way from discovering this vaccine to making the proper formulation and the GMP conditions could be tested clinically in humans. We tried about 6 different animal models, mice, rats, cotton rats, cattle, and did the first a phase 1 trial that was successfully completed a couple of years ago. So just show you some preclinical studies. In mice, we found that the vaccine was able to prevent any disease in mice and also was able to prevent replication of the virus in the airways. And recently, we completed a large study in collaboration with Iowa State University in response to a requirement by the FDA to test this vaccine on a newborn model. And we showed in calves using our vaccine, but the challenge was made with the bovine respiratory virus, syncytial virus, that has about 95% homology between the nucleocapsid protein from the human and the bovine virus, so the vaccine was supposed to work. We found that the vaccine was able to prevent clinical signs, fever, and also airway damage in cattle. We published this in 2021. So based on this data that was done under GLP conditions, and we submitted an application for the Chilean regulatory agency. It's called Public Health Institute, and the study was approved for a phase 1 trial in adults. And we found that the vaccine not only was safe, so this is the setup for the study. There were 24 people, 18 received the recombinant BCG, and 6 received the wild-type BCG. That was the control. In terms of safety, we saw very mild adverse events, and there was no severe adverse event whatsoever. And in terms of immunogenicity, because we want to consider this vaccine as a combined vaccination against RSV and tuberculosis, we were able to see antibodies against PBD, which is the mycobacterial antigen, as well as antibodies against the nucleocapsid protein from RSV. But most importantly, we could characterize very well the T-cell response induced in these subjects by the vaccine, where we found significant levels of gamma interferon secreting T-cells that we think are the protective component of the immune response triggered by the vaccine. We did this heat map expression of different cytokines produced by the vaccine in this cohort studied in Chile, and we found that the predominant cytokine is gamma interferon with very little production of IL-4 and IL-6. So the next steps, we are submitted already request for a phase 2 trial in newborns in Chile that's being reviewed by the regulatory agency. We're also working on an elderly study that we will do in Greece, hopefully this year. And also we're planning a phase 1b trial in toddlers in the United States in collaboration with St. Louis University. So just to end, I just wanted to tell you something that I think is very important to discuss on the RSV field, because most of the focus has been, of course, in the respiratory system And as we saw yesterday in one of the talks, there might be several other signs of symptoms that could be very severe after RSV that were actually, I think, like underscored due to the COVID pandemic that had to do basically with the central nervous system. So a few years ago, in 2010, 2012, based on a real case of a kid that actually suffered a sequela out of RSV infection, we wanted to understand the mechanism behind this influence of RSV infection on the central nervous system. And we published this paper in 2013 in PNAS showing that the virus, they say actually you could find virus RNA in the brains of mice and rats infected with RSV. And most importantly, when you do a learning test, so I'll show you two different learning tests. This is called water maze test. The mouse or the rat is set up on this pool that has a hidden platform. So when the animal is set up on the pool, is uncomfortable and wants to find the platform. And the platform is somewhere hidden under the water and in a room that has some visual cues. So the first time, the animal swims randomly until it finds the platform. But the second time, if the animal learned, is able to realize that the platform is closer to the triangle and far from the circle. And when you do this test with animals that were infected up to 6 months with RSV, so the acute infection goes only for a few days, for 7 days, you can see there's a significant difference between the controls, which are the green, the mock, and the RSV-infected animals. After the first trial, both of them take the same time, the controls and the RSV-infected. But after the second trial, while the mock animals are pretty good at learning where the platform is, the animals that were exposed to RSV have this significant deficiency in learning. Then finally they catch up, but after several attempts. So we did a second test. It's called marble bearing behavior. These animals hide everything is on top of the bedding of the cages they live, because if it's food, they hide it from competitors. If there are pups, they hide them from predators. And a just healthy animal will hide all the marbles after half an hour. A mouse that was infected with RSV has a very significant delay in hiding the marbles. So we published this in 2013, as I said. We also showed that if the animal is properly immunized with the recombinant BCG, there's protection against the CNS damage. But we also described in this paper that the phenomenon has to do with the crossing of the blood-brain barrier, because if we use an antibody that specifically prevents the crossing of cells across the blood-brain barrier that separates the central nervous system from the circulation, then the lack of response in the learning test is restored. So the animals are able to respond better. And we published this in 2020, showing that this increased permeability of the blood-brain barrier after RSV infection has to do probably with alterations in the cells present on the endothelium cells in the blood-brain barrier. Because as you see here, if you give a mouse Evans blue that normally is kept away, is kept out of the CNS, when the animals are challenged with infectious RSV, the brains become totally blue because the barrier becomes permeable to this molecule. And only this artificial molecule goes in, but if you look for monocytes, B cells, and T cells, you can find 3 and 7 days after infection immune cells present in the CNS of these animals. Then we tested whether the RSV can directly infect isolated astrocytes. Astrocytes are key cells for the maintenance and function of neurons. As shown here, using a GFP recombinant RSV, that after 24 hours, astrocytes are fully infected with this recombinant RSV. Now, this is very recent data. It's unpublished data that we worked together with Steve Varga in Iowa. And it is a very nice system where the virus is recombinant for a Cre recombinase. And if you use this virus to infect a mouse that is transgenic for a fluorescent protein that is fluxed, all these cells infected with RSV will bright. They will become fluorescent. And of course, you see a lot of red. This is a red fluorescent protein in the airways. But these are different areas of the brain. And these are that when you see cells that bright, they look pretty red after infection with this recombinant RSV, and this is a neuron that looks pretty amazingly stained by this fluorescence after infection through the nose. So this is something, this is a sort of a nice way of reproducing what we saw earlier on the wild-type virus. So this is all animal work. We published this paper in 2020. This is what I think is really concerning. This study in lactating babies. It's a 5-year study with 5 different seasonal outbreaks of RSV infection. And what we did in collaboration with a pediatrician and a psychologist was to do sort of electric mapping of the brain of children that were played with. So the psychologist was playing with these infants and just making sounds and showing figures. We will see a significant deficiency, and it's shown in this slide. It's a very confusing slide, but you just make a sound to the baby, and then you switch from one sound to a little different sound, and you show a picture. And the baby that is controlled here, right here, you will see response. And these are here in pink, where the arrows are the RSV infected kids that were released from the hospital. So they have, this is, we did this at 6 and 12 months. So this is a long-lasting effect that kind of recovers after 12 months, but there are several months where you can see this lack of response in terms of phonetic sound. So we think this has to be with speech learning deficiency. So we think that this has to do with the inflammation that is caused by the virus in the airways, and then the eventual crossing of the blood-brain barrier of cells that might carry even RSV antigens, and that could lead to CNS inflammation. So that's what I wanted to tell you. I wanted to thank my laboratory. These are pictures taken during the pandemic. We were working also on COVID-19 vaccines. So half of the people were at homes because we were in lockdown. And now, thanks to the vaccines, we are now with no mask in Chile. And this is my current lab. So thank you for your attention. And again, thank you for the invitation.
Thanks so much for your talk, and we can now welcome our next speaker. So our next speaker will be Dr. Anne Folsey. She's a professor at the University of Rochester Medical Center from Rochester, United States.
So thank you very much. It's a pleasure to be here and talk about this subject. It's heady times for those of us that have been studying adult RSV. And so I'm going to summarize 30 years of research in 15 minutes. So I can talk either really fast or maybe just hit the highlights. So I've chosen to hit the highlights. These are my disclosures. So one of the things that needed to happen before we could really move forward with adult vaccines was to show that there was actually a need for adult vaccines. And I'm not going to belabor this because Ed Walsh did a nice presentation on the burden of disease. But it started out with just a few reports in older adults in nursing facilities. And over the last 30 years, there's been quite a bit of literature showing that indeed there is a significant burden of disease. But I still think we have more education to do. So having decided that it was worth developing an RSV vaccine, you have to ask the question, like, can you even make an adult RSV vaccine? Realizing that all adult RSV is reinfection,
all adults have nasal antibody and serum antibody, and that unlike influenza, major changes, antigenic changes, are not felt to be a major reason that adults are infected with RSV. So early on, we did some studies with cohorts and natural infections, and we did observe that low serum neutralizing antibody and nasal antibody seem to be a risk factor for actually getting infected. But you really can't control exposure in those kind of studies. And this is a nice study, a challenge study that I believe Peter Opachaw may have shown. And it's looking at the ability to infect young, healthy adults. And so the top line is serum neutralizing antibody. And they did see that the serum neutralizing antibody in those they were able to infect was slightly lower than those that remained uninfected. The uninfected had higher titers. But there were big confidence intervals, and it was not statistically significant. On the other hand, those they were able to infect had significantly lower nasal antibody than those that remained uninfected. And this was statistically significant, and this probably isn't a surprise that nasal mucosa and antibody is your first line of defense against actual infection. But it still seemed quite plausible that one would be able to protect the lower airways, perhaps, by boosting serum neutralizing antibody. And so this is a study we did a number of years ago, comparing people that were infected with RSV who were outpatients versus those who ended up in the hospital. And it was a multivariate analysis looking at risk factors for hospitalization, using hospitalization as a proxy for severe disease. And we found that, as expected, the presence of underlying pulmonary disease was an independent risk factor, as was significant functional disability, so frailty. But then it was worth noting that a low serum neutralizing antibody was also significantly associated with being hospitalized. So now feeling like, well, it is disease worth trying to develop a vaccine for, and that maybe getting some signals that antibody is useful, we moved on. And so we've all seen this diagram looking at the RSV virus, the virus, and that on the surface, the major proteins are the F and G proteins. And partly because the F protein is more well conserved, it has been the target of most, not all, of the vaccine programs moving forward. So in the early days, these are just not a complete list, but some of the vaccine studies that were going forward. And I think the first study that Ed and I did with Wyeth was with purified fusion protein. And that was back in 1993. And initially, it was modestly immunogenic, got about 4-fold rises in those who were immunized. And it seemed like every time they purified it in a better way, in a different way, it became less and less immunogenic. And I now kind of wonder if, initially there was a better balance of pre and post-fusion F, and they were purifying out the pre-fusion. And then there was a study looking at cold-adapted with pre-fusion F, and then Sanofi had a primarily F-based vaccine, but it was sort of a dirty vaccine, and it had other elements in it, F and G. And not only were these products only modestly immunogenic, a lot of the programs just didn't get off the starting block because although the burden of disease is quite large in older adults, the incidence is low. So figuring out how to do a proof of concept study without spending a huge amount of money was always a stumbling block. And so sometimes they'd do an observational study, they'd look at the incidence, and they would get, they decide it's a too high risk and a bad business decision. So then along came Novavax with their nanoparticle vaccine, And also, MedImmune had a vaccine that was primarily F-based, but it was adjuvanted with a TLR4 agonist. And again, you know, when you just looked at neutralizing antibody, they were modestly immunogenic compared to what we now know. They actually did do studies where they looked at vaccine efficacy, and they did not meet their primary endpoints. So we all see this lovely diagram of the prefusion F, and it was, you know, a complete game changer when Jason McClellan learned how to stabilize the fusion protein in the prefusion state. And as we now know, it exposes site 0 and site 5, which have the ability to induce more potent neutralization, which was lost in the post-fusion conformation. And sort of a nice direct comparison that you can see here was this study comparing DS-CAV1 to MEDI 7510, which is then prefusion versus postfusion, very directly. And what you can see is the prefusion vaccine is in red, the postfusion vaccine is shown in blue. This is neutralization A, neutralization B, and the prefusion vaccine induces up to 8-fold rise in neutralizing antibody, whereas the post-fusion construct is really very modestly immunogenic with a 1.5 increase in titers. So the prefusion F as an antigen has stimulated a number of vaccine candidates going forward, and we have, it sort of looks like the COVID landscape when we started. There are RNA vaccines, and that's Moderna with pre-F. And I distinctly remember a conversation with Alison August in Malaga at this meeting where she was telling me all about, you know, RNA, and she's very enthusiastic, and I was very polite and then left going, well, why would you want to do that? Why don't you just give the protein? Shows you what a big thinker I am. Clearly wrong. And then the protein-based vaccines, Pfizer as a pre-F vaccine, and because there are some sequence differences in site 0, they've actually made a bivalent prefusion vaccine. And then the GSK prefusion vaccine, which is adjuvanted with AS01. And then finally, there are several vectored vaccines. Janssen is using the Ad26, which was used in their COVID vaccine, and it carries the gene for prefusion F, but they also have a mixture with soluble pre-F as the actual vaccine candidate to balance cellular and humoral immunity. And then Bavarian Nordic has a vaccine that, recombinant vaccine that incorporates multiple RSV genes into the modified vaccinia. So just as point of proof of concept, and so for years, we debated, you know, the value of the human challenge model to sort of get everybody off the starting block. And there was always this discussion, well, you don't want to throw the baby out with the bathwater because, you know, people don't get very sick. They get upper respiratory tract symptoms with the challenge model. You don't want something too virulent. But the companies went ahead and finally used the challenge models. This is data from Pfizer, but there was also a challenge done by Janssen and Bavarian Nordic, all with very positive results. And what this shows is if you take healthy volunteers and you immunize half and the other are given a placebo, and then you actually challenge them with the virus, there was very nice protection. And the first graph shows the viral load with the placebos shown in gray and the vaccinees shown in blue, and clearly, you know, just really shutting down viral production. And then this is symptoms, it's disease severity, but again, these are pretty mild symptoms, but mild or not mild, they really shut down any kind of symptoms. And so, as I mentioned, Janssen and Bavarian Nordic had very similar positive results. And so finally we have proof of concept. So full steam ahead. The programs, I think, were invigorated by these data and began actually doing clinical trials. Sort of first out of the starting block with Janssen. This is a phase 2b proof of concept study. It was a fairly large study, a little over 5,800 individuals. People were randomized 1-to-1 placebo-controlled trial, and they used 3 different definitions to define lower respiratory tract disease, which was the primary outcome for the study. And definition 1 required that you have 3 or more symptoms, signs or symptoms. Definition 2, you had to have greater than 2. And then definition 3 basically incorporated any ARI with RSV. And the vaccine efficacy for definition 1, which was the most severe, was 80%, and it had pretty decent confidence intervals. They also saw 75% efficacy with definition 2, and then, kind of remarkably, for any ARI, it was 69.8% effective. So this was really good news for the field that, something worked. In addition, they took a look at their breakthrough infections, and again, the vaccines are shown in that orange color, placebos are shown in gray. So of those individuals who had been vaccinated, who got RSV, they had a lower symptom score, and they used the RIIQ, which is a patient-reported outcome. And so the vaccinees had a significantly lower score than did the placebo well, they weren't breakthroughs, the infected placebos. And they also had, the vaccinated individuals had a quicker return to normal health, a median of 19 days versus 30 days, which is also kind of worth pointing out that these are kind of lengthy illnesses for older people. So onwards and upwards, the phase 3 trials began. GSK began in the summer of 2021. The results are in. They are applying for BLA. On March 1st, we'll be presenting to VRBPAC. Pfizer began their trial in the fall of 2021 and also applying for licensure, and will present to VRBPAC on February 28th, very soon. Moderna just released their top-line results, and we heard a lovely presentation from Eleanor Wilson yesterday. And then Janssen, their trial began in the fall of 2021, and that's currently in analysis. And Bavarian Nordic began their trial in April of 2022, and that trial is ongoing. So all of the trials had lower respiratory tract disease as their primary outcome. They all had slightly different variations on a theme, and I'm not going to belabor this, but they did all require that the illness be PCR documented, and that they mostly kind of looked at 2 definitions, more than or equal to 2 symptoms, signs or symptoms, or more than or equal to 3. The definition of severe disease varied a bit. The traditional definition is hospitalization, new or increased supplemental oxygen, or assisted ventilation, and that was used in the Pfizer trial. GSK expanded that a bit, that they could have a clinician-defined severe disease, which incorporated all the things the clinician was using. Did they need to come to the doctor's office? Did they need medications? Things like that. So these are the results from the GSK trial. This was recently published in the New England Journal, I think it was last week. I'm losing track of time. Primary outcome met. The vaccine efficacy for greater than or equal to 3 symptoms was 82.6%, and for severe disease was 94.1%. Now, there were only 2 hospitalizations, so most of the severe disease was the clinician and independently adjudicated illnesses. And interestingly, for any ARI, it maintained 71.7% efficacy through the trial. And this is the Pfizer data using two different definitions, greater than 2 symptoms or greater than 3 symptoms. And for the greater than 2, which is the milder disease, it was 66.7. But using that definition, using greater than 3, it was 85.7. And both of the primary endpoints were met with confidence intervals that were, the lower bound was above 20. Although because they got started a bit later, there were less events. And the main difference between 2 symptoms and 3 symptoms really seemed to be the presence of wheezing and shortness of breath, indicating that adding in an additional symptom did indicate more severe disease. And in addition, there was efficacy against any ARI of 62.1%. And then I was telling Eleanor, well, all I have from Moderna is the press release and a screenshot from MSNBC on their top line results was 83.7% effective. So she very kindly gave me a slide last night so there could be some real data. And comparing the vaccinated versus the placebos using a definition with greater than or equal to 2, the efficacy was 83.7. Using greater than or equal to 3, it was 82.4. So very positive results. So this is in no way meant to directly compare all the different vaccines. But what I will say is that there were low levels of events because of the pandemic, which I think made the whole thing challenging. And it's remarkable that these trials were performed and were successful, and that they were effective for both lower respiratory tract and ARI. They were safe and effective, which I didn't go over, or safe and well tolerated. And there were very few severe outcomes in all the trials, and those are things that will need to be studied. And they were also, by virtue of being a clinical trial, you could have underlying diseases, but you had to be medically stable. So, this does exclude some of the people that really need the vaccine the most. So when you line them up, this is using the same, it's not the exact same definition, but greater than or equal to 3, and this is not meant to say one is better than the other. To my mind, it means that they work. I find it very reassuring. They're all coming in, at around the same level, and this is ARI. So in the last minute, where do we go from here? Well, there's still a lot of work to be done. We need information on durability, revaccination, we need concomitant vaccination, combination vaccines, post-marketing safety. We need to do vaccine studies in some special populations that weren't in the studies. We need to have more data on severe outcome, which will probably lead to vaccine effectiveness studies similar to flu, cost effectiveness, and education of the public and providers. Just one word on, this is all we have on durability. This is the Janssen data. If you look down here to season 2 and 3, because they got started before the pandemic, they have a little data, and it was 76.1%, indicating that maybe the vaccine is durable. And there's a little bit of data on revaccination from Pfizer. Initially, you get about a 9 to 13-fold increase in antibody titers. These are Newt titers, which drift down over the year, and they're still about 2 to 4-fold over baseline. If you revaccinate, you get a boost, up to 5 to 6 times compared to baseline, but not quite as high, and then drifting down to about 2 to 4-fold over the baseline. So, an interesting decay was a little bit slower after revaccination than it was initially. So just to sum it up with some very basic comments, the pre-F vaccines have been found to be safe and effective in older adults, and the future looks very bright for both Grandpa here and his great-grandchild. But there's still a lot of work to be done. There's a lot that we need to know. So thank you.
Thank you, Anne. Thank you very much, and remain there. And I would call to the stage Alexis and Octavio for a very quick, I think, 10 minutes question and answer session. So if any of you want to place a question for the three speakers, they will alternate. And please go to the microphone. I see one there.
Yes. Hi, Natasha Lass of Vanderbilt University. Excellent talk, Dr. Falsey. So, given our talk this morning by Dr. Dagan, has anyone looked at decrease in pneumococcal invasive disease or pneumonia in adults, or did they look at that in the trials to see all-cause pneumonia? Did that go down?
So, I believe in all the phase 3 trials, they are looking at those outcomes, but they've not been reported yet.
Okay, thank you.
Thank you. Asun?
Thank you for the talks. This is for Alexis. We've been trying very hard to look for viremia in children. So I was wondering if you know the mechanism of CNS invasion in RSV. We haven't found viremia in otherwise healthy children and immunocompromised for sure, but how do you think RSV travels to the CNS? Direct invasion, PBNCs? Any thoughts?
Yeah, that's a great question. We think it might be through just through the blood-brain barrier, means like, spreading through the blood and eventually crossing. But also, we cannot discard direct infection through the nose and the airways through the olfactory bulb. Those are really tough studies to do in humans. And as you know, but there been some reports showing that in the spinal fluid has been found RSV RNA that's been described, but we cannot discard the role that inflammation plays. You may have so it's very hard to dissect between inflammation and actual viral infection of the CNS. So inflammation can also lead to opening of the blood-brain barrier. That's been shown in several models. So it's something that also might be taking place, like we see in SARS-CoV-2 infection, that the inflammation plus viral direct infection of cells, that the mix of the processes could lead to CNS and just dysfunction.
Thank you.
Thank you.
Yeah. Loud. Or if you go to the other. Either place your question and then you can switch to the other.
He's my boss,
Thank you.
so I don't know if I should jump before him.
You are boycotting him. We know.
Okay.
It's working now.
Okay.
Thank you very much. I'm not sure who should answer this, but I think it's Dr. Falsey. You mentioned, for example, special populations. And for me, we've heard a lot about young infants. Or maybe I should say, I'm from South Africa, and I used to run quite a large pediatric and adolescent HIV clinical service. And so when you're talking about special populations, in where there's a heavy burden of HIV, for example, all the time when it comes to policy formulation, every time when you talk to in a NITEC space, when you need to make an advisory decision, you always have this kind of knowledge gap in terms of whether the vaccine will work, apart from safety issues in these special populations. But I also note in this meeting that while we're talking about infants and adults, we always have this group of adolescents, which is actually an orphaned group within the medical practice spectrum. They don't seem to belong to anyone. And there's now a large cohort of adolescents that are either getting HIV infected or with chronic long-term conditions inherited from childhood growing into that area. Is there any data, not just with the vaccine, but also with the burden of disease in that group of population? And then secondly, of whether there's any consideration for this as a large, special growing population because of very good interventions in early childhood? Thank you.
So if I understand the question you're asking about whether HIV-infected individuals represent a special population that might be at risk, is that correct?
Yeah, that is part, yeah, that is that.
Okay.
And adolescents who are...
Adolescents, right. So I believe it's not well studied, but there are data that HIV is, at least in adults, is not associated with severe RSV. There's, of course, some exceptions. If they're not on treatment, they may excrete RSV for a prolonged period of time, but they tend not to get particularly sick. I think pediatrics may be a different scenario, so, but as far as adolescents, I don't think they're well studied.
Thank you.
Octavia, could I ask a question, please? This impact on innate immunity and on antibody production that you've shown is defective in infants under 6 months of age. Is there a dose effect? Is there an effect, I mean, comparing RSV infection, asymptomatic infection or mild infection compared to severe disease, hospitalization? Is the viral load of any importance in driving immune responses? That's the question.
Well, that's a really good question. Is the viral load of the more severe disease correlates with antibody response? I think the preliminary data, Asun is the one who is doing the analysis, not so far, right? There is not a clear correlation between disease severity and the antibody response, unfortunately. The part that we are trying to figure out if it's the interferon signature predicts or not the antibody response, that is still it's a complex analysis that we are trying to work. Can I ask another question to Alexis?
Why not?
No, because this is relevant to the severe disease. And I was wondering if there is a correlation between severe disease and the neurologic outcomes, if these are kids have been in the ICU or not, if you have any data on viral load, or if there is any genetic predisposition, because most of the reports, clinical, that we look at, description of RSV in the CNS come from Asia, right? Japan and Taiwan and Korea. Do you have any sense of that?
Thank you for the question. Right, so the study we did with the learning of speech was comparing mild RSV with severe RSV, and we also had controls of children that were hospitalized because of the reasons. So it has to do with severity. And of course, I think some genetic predisposition might play a role, as it does, as you show in your talk, that different immune responses, the nature of the inflammation is different between different people, and of course the genetics apply over there as well. So I think it's still something that we need to study quite a bit, and vaccines might actually help solving that issue. But it's been like, hidden from science and medicine for many years, and many kids that suffer probably severe RSV had unseen symptoms that might have affected their lives, like, in school later. That's something that we also will doing with attention deficit disorder. That's another study we're doing at the moment.
I have also another question for Dr. Folsey. So thanks so much for your very interesting talk. And as you said, there's still a lot of work to do. So I was wondering if you could comment a little bit, since we know that older adults usually take flu vaccines, and how do you see this? It's very interesting and exciting to see all of these great results from all these different trials, but I was wondering in terms of administering doses, if this would be, given together, how this would work, and if you have something to comment on this. Thanks.
Yeah, well, that's a great question. It's sort of on my list of things to do. I think implementation, we still have work to do in educating primary care doctors that this would be a good thing to do in their older patients and people with high-risk diseases. And we still don't know yet, because it depends on durability, will it be an annual vaccination? If it is an annual vaccination, how will that bump into COVID and flu vaccine? And so those studies are actually, concomitant vaccination is ongoing, and the data are not available yet. But durability, we actually don't know yet.
Thanks.
Well, I think we're almost done, so it was a great question.
Can I make a comment? She's 44 seconds there. No, going back to the question of our colleagues from South Africa, I think adolescents have not been studying vaccines. I mean, if you look at flu, in the US, there's a peak of adolescents who are previously healthy, who go into the ICU with influenza. So maybe something that we haven't understood yet of the immunology of the adolescents, that whether they have risk factors like chronic lung disease or HIV, that we need to study in depth, because this is a population completely understudied on vaccines.
Well, and a very pragmatical consideration. I think all of you who are pediatricians took again all the pediatric diseases when we went to the School of Medicine and the School of Specialty. So there's no doubt that adolescents or young adults could be the next population to explore and to assess. But with this in mind, I think we can thank all the speakers. Thanks Anne, Octavio, and Alexis for this very inspiring session. Thank to my co-chairperson, Octavia Prunas, and have a nice pause and a good lunch break. And in half an hour, in 20 minutes, there will be, for those of you who will, another satellite symposium here. Senti, grazie a te. Grazie a te per essere saltata sull'ultimo secondo, ma mi sembra sia andata bene, siamo stati nei tempi, ci sono state un po' di domande, che è sempre una cosa.
Era anche una sessione. Però è bello, queste sono un po' di cose con i modelli matematici, puoi esplorare, no? Queste diverse strategie.
Questo sì, questo è, direi, questo aspetto qui nel campo della ricerca per l'RSV, con tutte queste opportunità che ci sono, è molto importante, perché ad esempio io ne sono abbastanza, direi completamente digiunto, come la maggior parte di noi che siamo clinici, quindi al di là di qualche nozione di statistica che ti serve per poi arrangiare i papers per la pubblicazione, però modelizzazione, le strategie di modelizzazione, tutte cose poi arabo. Quando poi passi a ipotesi, opzioni di azione su grandissimi numeri come sono queste, migliaia e migliaia di pazienti, tu devi avere veramente un'infrastruttura culturale.
Sì, Octavio, che ora sta
che non è
le attrae. Di alternare. Quindi quello che poi vuole fare il mio gruppo, fare simulazioni, poi far vedere diversi scenari,
hai fatto simulazioni sull'influenza del Covid con la circolazione del paese?
Ha fatto tanto la mia Gigi del gruppo Dene, lui, che hanno visto tanto come il Covid ha impattato sulla stagionalità. Però credo sarà una delle prossime cose che ci farà capire che il problema vero sono i dati, e avere disponibilità di dati per informare la
Che io ho ben presente alcune che porto sempre parlando di Covid awareness, alcune modellizzazioni fatte negli Stati Uniti.
Sì, esatto. Thanks so much.
Un gusto.
Thanks. Esatto, sì.
Laia está, primer piso como yendo al baño, en una salita de mano izquierda. Estamos
Da qui si
trabajando.
arriva che ha avuto l'andamento
Donde
perturbato.
A la derecha están los baños. Yendo para ahí como una salita, te vas a dar cuenta, está ahí sentadita. Y le prohibí moverse, así que va a estar ahí. Ahora subo también.
¿Te veo ahora aquí?
Sí, sí, sí.
Quella è una cosa molto interessante perché ha un impatto pratico sulle raccomandazioni societarie. Quest'anno in Italia la società di neonatologia ha dovuto dire, prima dell'inizio della stagione, anticipate la profilassi a settembre perché già ci erano. 2 settimane fa ha dovuto dire fate più delle 5 dosi, fate anche 6 o 7 perché ancora ci sono queste cose qui Senti, grazie.
Ti faccio sapere chi mi va Pantoli, lo sentirò oggi, ti sono un WhatsApp.
Grazie, è molto gentile. E tanto il numero tu
ti scrivo su WhatsApp.
E al di là di quello poi essere già il 7.
Certo, me lo fisso. Perfetto. Felicissima, sì.
Poi ne parliamo, se dovesse venire o volesse venire qualcuno del tuo gruppo.
Sì, dai, volentieri, sì, sarebbe bello.
Assolutamente.
I fondi ne abbiamo, secondo me, per far venire.
Tu non c'è bisogno che dai fondo ai
Poi
fondi.
a casa ce l'ho, sì, esatto.
Però se qualcuno sai vuole fare qualche iscrizione, ne parliamo.
Esatto.
Noi abbiamo un numero abbastanza fisso che dovrebbe non eccedere i 250.
Ok.
Però in base a quello che sono disponibilità.
Perfetto. Va bene.
Va bene.
Bella. Grazie.
A te, ciao.
Acabou que não trouxe todo mundo. Não, eu imagino que assim, ali dentro do bairro do seu condomínio, você fez a nossa, né? Você tá
Brian, no, I'm sharing. I'm sharing. This will look stage managed.
Infectious Diseases at Vanderbilt University Medical Center.
Great, thank you so much for joining us, Natasha. So Saad, the original co-chair, really sends his apologies because of a complicated situation that none of us could have any control over. He wasn't able to come to this beautiful city. So I think we're all excited about this session because the interventions against RSV, the preventive interventions against RSV, those vaccines and those monoclonal antibodies that we've been hearing about, they're reaching the stage where it's actually, almost ready for them to be licensed and introduced to countries. And this is a stage where they can have a huge impact. But governments and organizations around the world, they're going to need to know how's the best way to use these interventions. How do we get the most value from these interventions? Should we introduce them or not? And to help us with that, we have 3 speakers from really different perspectives and parts of the world telling us about how we can work out the cost effectiveness and the value of these interventions. So to start off with, I'm really delighted to welcome Dr. Cheryl Cohen from Wits University, who's going to talk to us about, health economic models and using country-specific data to inform them.
Thanks, Mark, for that very enthusiastic introduction. I'm not a health economist, I must disclose this, but I have been presenting data from this health economic study at more than one meeting, and I have noticed something, which is that the health economic session is always the graveyard session of the conference. But
we save the best for last.
Exactly. With that introduction, I think it's because the best is always saved for last. So I'd really like to thank the organizers of the meeting for the opportunity to present some data on health economic models for RSV from Africa. And these are my disclosures. And I think Mark has really said it all. When we think about vaccine-preventable diseases, I think the feeling that's been around for the last 3 days is that as a community, we're really at that exciting stage where for years we've been doing the work to demonstrate burden, to demonstrate the need for an intervention, and we're really poised, ready to introduce that intervention because products are being licensed as we speak. And at this time, I think what's really critical is that all over the world, different countries at an individual country level are having to make decisions about vaccine introduction, whether to do it and how to do it. And I think there are a number of different data elements that are really important from a country perspective in terms of this decision making. And first, of course, and really important is burden of disease. And not just, how common is it, but really looking at the risk groups. And for RSV, of course, the most important risk factor is really age. But also really thinking about the different severity endpoints. So going all the way from mild disease to mortality. Again, for respiratory disease, there's a really broad spectrum of illness. And if data are available, really to think about this in relation to other vaccine-preventable diseases. I think once you have burden, though, when you're thinking about paying for an intervention, you need to attach that to cost. And the cost needs to be the cost of the disease, but also the cost of the intervention and the delivery of that intervention. And of course, we bring those aspects together with cost-effectiveness analyses. And there are a number of other factors that are important to consider. Just one that's at the bottom of my list, and I'll talk about it a little bit at the end of my talk, which is the potential for any intervention that we have, particularly in the field of vaccines, to interrupt transmission. Because we know from other diseases like PCV that if a vaccine interrupts transmission, this can really dramatically affect the impact and the cost-effectiveness analyses. But firstly, for the first sort of 2/3 of my talk, I'll be presenting some data from a collaborative study that we conducted, really trying to look at the disease and economic burden of RSV and cost effectiveness of different interventions, and examine the role of really getting high quality local data and how this can affect cost effectiveness analyses. And the study had a number of collaborators. You can see them listed on the slide, and in fact, many of the individuals involved in the study are here today in the room. The study focused on 2 countries, Kenya on the east coast of Africa and South Africa at the southernmost tip of the continent. And the idea we had with this study was
was that we know that the interventions that are coming, both maternal vaccination and monoclonals, have a very time-limited durability of protection. And because of this, understanding the burden of disease by month of life in fine age bands could really be important in terms of driving cost-effectiveness models. In other words, understanding how left-skewed the data are could be important. But these data are very difficult to get, right? It's quite difficult to measure burden of disease in fine age bands because you need large data sets over multiple years, and these data aren't available in many countries. So what we really wanted to do was build on long-term surveillance data in both South Africa and Kenya and try and analyze these data to generate high-resolution burden data for different endpoints, local costing data, and then feed these into cost-effectiveness models and see whether the local data on age distribution really had an impact. So the burden data have in fact been presented yesterday at this meeting by Brian Inyawanda from Kenya, so I won't really spend a lot of time on it, but just to show one slide to remind you from what he presented yesterday. On the left you have Kenya, on the right South Africa, at the top you have the mild disease, and at the bottom severe disease, and for each figure we have the medically attended and the non-medically attended illness. And I think the overwhelming message in this figure is that when we look at the milder disease, it's really distributed across the different age groups in the first few years of life. But if we look at severe disease, both hospitalized and non-medically attended severe disease, in both countries you see this extreme left skewing of the hospitalizations, with the peak incidence of hospitalization really being in the first month of life. Now, the last few years have really seen a revolution in terms of our understanding of RSV-associated mortality in Africa, and particularly the out-of-hospital mortality burden. And we published from South Africa. At the top left, you can see a study, now a little bit old, from 2018, where we estimated that amongst children less than 5, 1 in 4 RSV-associated deaths occurred out of hospital. But more recently, the Bill and Melinda Gates Foundation has funded a number of studies where they've actually looked in other African countries, taking post-mortem samples from babies that have died and testing them for RSV. And these studies have really revealed an astoundingly large burden of out-of-hospital mortality, with up to 2/3 of RSV-associated deaths actually occurring out of hospital. And I think this out-of-hospital mortality burden is really important as we think of the interventions that we have at hand, because these children, no matter what advance we make in treatment, they're not reaching care, and so they can only really be reached by preventive interventions that have a wide delivery within the population. So taking all of that together, the hospital data, as well as the data on out-of-hospital deaths, you see here the RSV-associated mortality burden in South Africa and Kenya. And again, really just to draw your attention to the extreme left skewing of the data, even more pronounced in the mortality than in the hospitalization data. And it's this real concentration of those severe endpoints in the first few months of life that is key to the cost effectiveness. So what we did in the study was we took this local data from the 2 countries, we took the burden estimates in fine age bands, we generated new local data for both settings on the cost of disease, and then Mihaly Koltai, who led this analysis and works at the London School of Hygiene and Tropical Medicine with Mark Jitt, he took all these local country-specific data and he fed them into a pre-existing model that was published by Lee et al. In BMC Medicine, and Philippe, who's speaking after me, also was very involved in the development of that model. And he really tried to see whether the local data would give a different result from the previous analysis from Lee et al. Lee et al. Had used data from meta-analyses from community-level data, but not actual local country-specific data. He looked at 2 interventions, maternal vaccination and monoclonal antibodies, and at the time we parameterized it on the latest data that was available from clinical trials, and we assumed a 3-month protection for maternal vaccination and 5 months for monoclonal antibodies, but there were a number of different sensitivity analyses that were done to explore variation in the different parameters. And this slide really summarizes the bottom line of his results in terms of the cost effectiveness of maternal vaccination and monoclonal antibodies in the two sites. I think the first message is that in our setting in Africa, the daily burden is dominated by deaths, which makes up really 95 to 97% of the burden. So mortality is really important, and these interventions have a potential to substantially reduce RSV-associated mortality, which is the most important cause of respiratory mortality, which is the top cause of mortality in our settings. And with reductions, depending on the product and the setting, from between 10 to almost 50% of all RSV-associated mortality. And in the figure, you can see a summary of some of the different analyses that were done. Just to orient you, on the left is Kenya, on the right, South Africa. This is the cost, incremental cost per daily averted. And the red is monoclonal antibodies, the green is maternal vaccination. And for each one, we really explored 3 different price points, from the lowest price point to the highest price point. I think the first message is that when you incorporate these local burden data, it really has an impact on the incremental cost per daily averted. In fact, so much so that in South Africa, at the lowest cost, both interventions were in fact cost saving. And even for Kenya, at the lowest cost, it's 144 or $397 per daily averted. But cost is really important. So as the cost goes up and you change the assumptions, these amounts can get really high. So I think one of the critical points is that the cost at which these interventions are made available to low and middle income countries will be really important. So just to highlight for this first part of my presentation, the main findings of our study is that when we really looked at 2 African settings with high-quality, long-standing, high-resolution data, we really found a higher disease burden incidence for children, particularly in the first 3 months of life, than had been suggested by community-level meta-analyses. Because the interventions confer the highest protection in the first few months of life, when you put this into models, it leads to a substantially larger reduction in disease burden and more favorable cost effectiveness in both countries compared to those sort of more general models. But the cost of the intervention is key. And I mean, in summary, interventions against RSV may be more cost effective than previously estimated following incorporation of these parameters. So I'm going to just move away from that for the last bit of my talk and talk a little bit about RSV transmission and also thinking to vaccines for RSV in slightly older children. And I'll present just a little bit of data from a study that we conducted in South Africa looking at the incidence and transmission of RSV. And the study that I'll be presenting really was based, again, on work conducted in Kenya by Patrick Muniwoki and James Noakes, who did a very similar study in Kenya, and we really built on their work to try and do a similar but slightly larger study in South Africa. The rationale for the study is that there are on the horizon, a little bit further away than the interventions for the first 6 months of life, are vaccines that are targeting children over the age of 6 months. And these vaccines also have a potential for major impact, first because there is a substantial burden of disease in this age group, but also because these vaccines do have the potential to interrupt transmission, and this could theoretically reduce overall burden in high-risk individuals who are not vaccinated, such as the elderly and young infants, through indirect effects. And so we conducted the study really aiming to estimate the burden and the transmission of RSV in different communities, and particularly to understand the role of young children. So first was a prospective cohort study. It was a very intensive study conducted in a rural and an urban site of South Africa, and it was conducted over 2 years, in 2017 to 2018. Each year at each site, we randomly selected 50 households, and we enrolled everybody in the house, and then we followed them up very intensively for 10 months. We visited them twice a week, and at each visit from each household member, we collected a nasopharyngeal swab and tested it on reverse transcriptase PCR for RSV. We collected swabs irrespective of symptoms, but we did collect data on symptoms and health-seeking behavior. And this intensive follow-up led to a large number of samples, over 80,000 samples. We achieved over 90% follow-up in terms of scheduled visits. And this slide, I just have one slide really to summarize the results, which are really quite astounding in terms of the burden of disease. So the left graph shows the incidence rates of RSV infection in the population by age. The blue bars are just infection, irrespective of symptoms. Dark blue is a first infection, and the light blue bars show repeat infections. And then the green bars are symptomatic infection with different shading for different symptom complexes, and the red is the medically attended illness. And really to highlight the huge burden in children less than 5. So 70 to 80 per 100-person seasons is the incidence of RSV infection in those children less than 5. But even in adults, it's still really a high attack rate each year. And on the right, the figure shows the symptomatic fraction by age group, so the proportion of all infections that have symptoms. The gray is asymptomatic, and the green, again, is symptomatic. The red is medically attended illness. And you see very beautifully that classic U-shaped distribution in terms of the symptoms being concentrated at the extremes of age. I mean, the paper is soon to be posted on an open access server, so I won't give you all the details, but the bottom line is that young children drive transmission, and this isn't surprising. We found these very high attack rates in young children. We found that young children were responsible for a high percent of introductions into the house. Children aged 1 to 4 accounted for almost a third of introductions into the household, and they were also more likely to acquire infection given introduction into the household. We also did a contact study, and these young children have the highest contact rates in the community. And so we concluded that vaccines targeting young children have the potential in Africa, especially where we have these very high attack rates, to interrupt transmission. But one of the things we observed is while there's this potential, what we don't know, in fact, is the mechanism of action of the products that we're giving. So we don't know whether these vaccines actually affect transmission. And of course, COVID really brought out how important a question it is, that a vaccine might actually attenuate severe disease but not have any impact on transmission. And so last year, we were able to conduct a pilot study. In fact, this study was an influenza study primarily funded by the US CDC. It was really just a pilot. We called it the ICID study, and the aim of the pilot was really to explore whether using these platforms with very intensive follow-up and very high attack rates, one could actually extend them to be a platform to perform clinical trials where you randomize children to either receive a vaccine or not, and then actually measure the endpoint of whether the vaccine is preventing infection or illness, or is it actually just attenuating illness? And then one could also do correlates of protection, and if funding allowed, in fact, look directly at onward transmission to household members. This was just a small pilot. We enrolled 87 children. We were also exploring sort of cheaper ways of doing things. So we did 3 swabs a week, but we used mother-collected swabs, which was very successful. We used electronic symptom diaries. And again, we achieved very high follow-up, very high compliance, and high attack rates. The RSV attack rate was a bit lower, 44%, but this was because, as you can see, we actually, we missed the RSV season because it was a flu study, and our RSV season comes a bit earlier. So we actually only got the second half of the RSV season, but still very high attack rates and very high symptomatic fractions, about 50%. So really giving you good power to potentially evaluate these endpoints. So just to conclude, I think monoclonals and maternal vaccines to prevent RSV in infancy can have substantial impact on hospitalizations and mortality in sub-Saharan Africa, and accounting for the true age distribution at a local level improves cost effectiveness and may be useful to do in some other settings, for example, Bangladesh or in Asia. But what we need is available, affordable interventions, and vaccines in children slightly older in Africa could also have the potential to reduce transmission, and potentially we could evaluate these interventions using these platforms with very intensive follow-up. Really just to acknowledge the many collaborators on the burden and costing study, as well as our funders, the Bill and Melinda Gates Foundation, PATH and Sanofi, and the CDC. And then for the first study as well, a very large collaboration, and to acknowledge all the partners and the funders, and of course the participants in these very intensive studies. Thank you.
Thank you, Cheryl. That was a really clear presentation with some really important messages. I think we have time for maybe 1 or 2 quick questions for information. We'll have more time for general questions at the end, if there are any. If not, I think you've been so clear that actually you really got the message through. Thank you. And I'll hand over to my co-chair.
Our next speaker is Ranju Baral, who will be talking about cost effectiveness of respiratory syncytial virus maternal vaccine in low and middle income countries. And she works for PATH.
Thank you. I have to lower it down. Thank you all for being here, choosing to be here at this point in time into the conference. This speaks to your commitment to RSV prevention. My name is Ranju Baral, and I work as a health economist at PATH. And today I am very pleased to be here presenting some of the findings from the cost effectiveness of maternal RSV vaccines and focused on the low and middle income countries. What we heard from Cyril before was the country specific with the, using the local data on the cost effectiveness. What I will be focusing is on more general global level analysis looking across various countries. So just to outline of my presentation, I'll start with a very quick background, followed by also introducing some of the current evidence around the country-specific analysis, in addition to what Cheryl just shared, what are the other evidence that is being generated and where they are. Then I will go into focus specifically into the PATH model, summarize the inputs, assumptions, some of the key assumptions and findings, and then finally conclude. So for the background, as most of us here know, and also Erin yesterday presented that RSV interventions were considered for Gavi, the Vaccine Alliance, as a portfolio as a part of its VIS, or the Vaccine Investment Strategy, back in 2018. And PATH, along with the model that Cheryl introduced from, and other models from University of Antwerp and London School and one other model, we generated prepared the vaccine impact estimates to inform the Gavi VIS investment strategy in 2018. Following which we published a joint publication as well that came out in 2020, I think. Following that, PATH conducted subsequent analysis to inform different decisions for the partners as well as donors around the further development and the use of these vaccine interventions. We expanded on the model that we used for the Gavi for the Gavi VIS and expanded it to incorporate the cost effectiveness component and did some analysis and published that in 2021. What I will be presenting later today is the update to that publication based on the new data from the new clinical trial as well as the burden data that has come after the publication. Whoops. Okay. And that's the other publication at the global level that is currently available from Antwerp and London School's team. So here's a snapshot of the country-specific analysis that are currently available. And this table shows you the distribution of the studies that are currently happening or are available by the WHO regions and the World Bank classification of income groups. And just looking at it, I think what the main message that we can draw from here is that, yes, there is limited information around the cost effectiveness, but this pool is slowly expanding with, as you see, there's a fair representation across the different regions and low income and across the income groups as well. What we heard from South Africa and Kenya, I think that paper is under review, Cyril, currently. We have a few publications from the UMIC on Turkey and China, and another study from the LI's low-income country, Mali, is already available. A handful of other countries across the different regions are currently underway, and just wanted to note that the studies in the italics signify the work that PATH undertook along with the partners, and most of those on the underway category are going to be completed by the end of this year. So we'll have a pool of country-specific information available as well. So now we're at the stage where we are with regard to as the countries are preparing for the country-specific for the introduction of the RSV interventions, especially maternal vaccines. I think, oops. Okay. Now that we're nearing the introduction of the vaccines, or as well as the monoclonal antibodies, the countries will want to seek their own country-specific analysis, which are usually very rich, as Cheryl just presented, with the country-specific data on the disease burden, the cost, and all those inputs and assumptions that the country can use to come up with the more robust country-specific informations that they can use for their own decision-making when the time for the introduction comes. And to support the country level, to generate such information, PATH has collaborated with the London School of Hygiene and Tropical Medicine to develop the RSV module for the UNIVAC module. So UNIVAC, or the Universal Vaccine Model, is a simple, I don't know if I can say simple, but it's an Excel-based, user-friendly model that is a user-friendly model that has already been used by various, more than a couple dozen countries for other vaccines impact and cost-effectiveness estimates generation, for example, for PCV, Rota, HPV, etc. So I think there are like 6 or 7 other antigens that vaccine that are already incorporated into that model, and countries have been using that to inform their own decision making for those antigens. So we have very recently completed, including RSV as the module, so that they have the tool tool for the disposal when the time comes, and if there are interest as the country express interest. So now switching into the summarizing the global model from the country-specific model to the global model and the updated model that we, I'm just using the wrong clicker, okay. So here's a brief methods overview. It's at a very high level. It's a very simple static population-based cohort model, and static meaning that it does not incorporate some of the indirect effects that Cheryl was saying that might be important in terms of accounting for all the total benefits. And the model simply uses, looks at the RSV maternal vaccines impact and benefits and compares it to the status quo. Just wanted to say that this model, we also have used it for the MAB MAB cost effectiveness analysis, but the focus of this presentation I only focus on the RSV maternal vaccine, and primarily because I think the cost of the product, the sustainable price for that product, especially in the context of the LMICs, is largely unknown for the MABs at this point in time. So the model takes a health systems perspective and is currently looking at 133 low and middle income countries as classified by the World Bank. And the analysis covers a 10 years period. I think there's a typo, up to 25 to 2034. And the costs are presented in 2022 US dollars. So here are some of the key inputs and assumptions that go into the model to generate the estimates. We're looking at the target population for year 2025 at roughly 124 million pregnant women across this 133 countries, and there's the distribution of those pregnant women across the 3 income group as well. For the intervention, we're looking at the single-dose vaccine that is given during the 24 to 36 weeks as a part of the antenatal care service. For the coverage, we estimated the proportion of pregnant women who would come visit for the ANC during that specified gestation window, and to project that proportion, to calculate that, we use the data from the DHS, the secondary data available around the timing of the first ANC visit and the ANC coverage, etc., to project the proportion of women who would visit there. For the vaccine product characteristics, this is the major update from the analysis that we previously published. We used the Pfizer November data release and used the 6 months, the efficacy values at the 6 months for the baseline analysis. And just to note that these values that are listed here are all for the baseline. We did do several scenario analysis and sensitivity analysis for which we used a different set of values. For the intervention cost, we assumed the vaccine would cost $3 per dose in the Gavi-eligible countries and $5 per dose for the non-Gavi countries. We did not make any assumptions around further subsidy around introduction or anything for any of the countries. For the intervention delivery cost, again, there is no information available, data available out there around how much it costs to deliver the maternal vaccines. So we use what was available from the literature, which is the incremental economic cost of delivery per dose, and that is reflecting the cost of delivering the vaccines within the existing EPI systems and system. So that is the mean cost for the low-income countries. It is 74 cents, and that for the other countries is about $2. For the treatment cost, again, we used the systematic review to inform the cost of seeking clinic visit or the outpatient care, as well as the RSV hospital admissions, inpatient care, which are respectively $62 and $368. And just to remind that, the global level analysis, all these inputs are assigned for across all countries. So this serves a particular purpose of looking at how the direction of cost effectiveness at the global level, whereas the importance of generating more robust insights from the country-specific, using the country-specific data, that just underscores that fact. Moving on the disease burden inputs, this was another update as well. Previously, we had used Tingxi's disease burden estimates from 2017, and Lee et al., again, this is from the Edinburgh team, the update to that burden, disease burden. We extracted the disease burden for different outcome measures by different income groups, and then just translated that into the per 100,000 children. I think the burden estimates were fairly comparable across between the two iterations, although I think the death was slightly lower in this particular iteration. For the distribution of disease by age, we used the hospital admission data from two unpublished data from Argentina and Vietnam, as well as the 4 other studies that were identified in the systematic review, and we fitted those refitted those to get the distribution of age distribution. The blue bars there are showing the RSV non-severe cases, which reflect approximately half of all the disease burden concentration in among less than 1 year. The red bars represent about 2/3 of the disease burden being focused in the infant under 1 year. So here are the results. So this is the aggregate health impact results that aggregates all the results across for different outcome measures across all the 133 countries, and I chose only 2025 estimates for 1 year. So the column in the middle reflects the disease burden without any intervention. So you can see that there are roughly 33 million cases, both severe and non-severe disease burden among children under 5 estimated, and the deaths at around 107,000 deaths among children less than 5 years. With the intervention, on the last column is the averted burden, and as you can see from the numbers, most of the disease burden averted is around the severe cases, hospitalizations, and deaths. I'd like to direct you to the bottom 3 rows. That number translates basically to about 20% of the deaths among less than 5 years old being averted due to the intervention. And if you just focus on the less than 6 months old, where the impact of the vaccine is coming from, then it accounts to roughly, it is projected roughly 1/3 of those death burden could be averted by the intervention. If you translate those numbers into how many, how many children deaths are averted by vaccinating 100,000 pregnant women, overall across all countries, roughly 31 deaths could be averted by vaccinating 100,000 children. This is the same data or the same estimates, just disaggregated by different income group. I won't go into the first half. The second half, I think what you can see is the proportion of death averted is increasing. If you look across the three income groups, it's 17%, 19%, and 32%. Respectively for the low income, low middle income, and upper middle income. And I think part of that is reflected by the coverage that we are assuming in this particular case. And I think I forgot to mention the coverage. If you look at that coverage, the average was 66%, whereas the range of the coverage, expected coverage, ranges somewhere from, I think, 4 or 5 to up to 95% of the pregnant women being vaccinated. However, the impact, if you look at the number of deaths that could be averted by vaccinating 100,000 pregnant women, is highest among the low-income countries, almost 6-fold higher than that in the upper middle-income countries. And not surprisingly, it's because most of the burden is, concentrated into lowest income category. Now, here are some of the cost-effectiveness estimates. Again, total and by country income group. The healthcare cost averted across all the countries in 2025 would be projected to be somewhere around 440 million. And then the cost of vaccine program implementation is projected to be somewhere around 525 million. And if you take the net cost of that and then divide it by the impact that could be generated from this, which is the averted DALY, or the disability-adjusted life years, that would give you the incremental cost-effectiveness ratio. And what that is basically how much additional cost is needed to improve or to get that marginal benefit or marginal benefit. Looking at the number, the average cost-effectiveness ratio here, this analysis under the assumptions that we have assumed is roughly $377, and the number is lowest in the low-income country, and the range across all the countries here. I think there are like 28% of the countries. It was projected to be cost-saving, and the values ranged up to 2,800. How this number compares to the previous analysis is these numbers are with the updated, better updated efficacy and protection number and the baseline. The cost effectiveness has improved, meaning that the cost ICERs has decreased. Because in the previous analysis, we were using lower, low efficacy and the much lower protection as suggested by the Novavax trial back when that data was available. And also, we have compared this model with the UNIVAC model, which I previously talked about. The results are we had recently completed not a harmonization, but the model comparison exercise. And the two models with the harmonized sets of inputs and assumptions, the two models are projecting, very, very close estimates. So what do we do with that cost effectiveness number? What does it mean? I think to interpret that, how do we interpret is, it has to be, it is, I think we need a cost effectiveness threshold to say whether that is cost effective or not. So it is, across all the LMICs, there's no such standard threshold that is available, and a typical threshold, we use the GDP per capita as a threshold for the WTP. And what this graph is showing is that if we're willing to use that WTP threshold as, the GDP per capita as a willingness to pay threshold, then then in the y-axis, you're seeing the percentage of countries that are willing to pay, that would be willing to pay under that threshold for the maternal, for this maternal vaccine. So what this graph suggests is that, almost all countries would be willing to pay under less than 50% of their corresponding, GDP per capita, and about, almost 90% of the countries would be willing to pay at 20% of the GDP per capita, which, traditionally speaking, it's an indicator of being highly cost-effective. But again, this will have to, that is not the standard that is used, and there are other recommendations to sort of, make that interpretations. We also looked into some other influential parameters, and I won't go into details, and I think all this very closely aligned with what Cheryl already shared. The cost-effectiveness parameters are very sensitive to the product price, how much product price, and we see that if we double the product price, the change from the if we, increase the product price, double the product price, it is very sensitive to the, the cost effectiveness are going to be much, much lower than what we just saw under the assumptions. Sorry, I don't know what is happening here. I know, do we, okay, okay. Did I miss? Am I doing anything wrong?
Do you want to go back to your concluding slides? Keep going backwards.
Okay. I'm going to go to there.
Here we go.
Yes, thank you. So I know I'm almost on time, so just wanted to mention that the cost-effectiveness analysis, the outputs are as good as the inputs are. So I think we need to look at those numbers that I shared with with the fact in mind that we're using this global level data derived from the systematic reviews, and these are not country specific, but this serves a purpose at a certain level when we wanted to look at a very more general level and understand the directionality of cost effectiveness and the potential cost effectiveness. And talking specifically of this model that we looked at, it is a static model, and we do not incorporate any indirect effects or the hard effects as might be available as nor we considered any potential benefits of, additional benefits that we had previously heard in the last several days around the potential for of these vaccines to impact the other lower respiratory tract infections, etc. And there is still a lot of uncertainty around the model parameters, including the age distribution of these diseases, vaccine product price, et cetera, et cetera. We did not consider the targeted vaccination, which might have potential to sort of, bring down the cost as well. And of course, another thing is the coverage. We do not know how, what the coverage, potential coverage of these interventions might look like, and how those vaccine products are going to be delivered. It's not yet defined, although we have started at PATH to sort of, slowly understand from the country how that is going to look like. So I think I'm already on time. I'm just going to stop there. And
thank you, Dr. Burrell. We're going to hold off on questions because we have about 20 minutes, and we'll bring all the speakers up for more. So thank you for that wonderful presentation.
Great, thank you very much. And for our last speaker, we are going to move to Europe now, and we have Professor Philip Bertels, who's going to tell us about the exciting work that the Rescue Consortium in Europe has been doing to understand the value of vaccines and monoclonal antibodies.
Thank you, Mark. So this is the Rescue project, European project, which comes with a disclaimer, of course, since it's a public-private partnership. And so I'd like to make that clear from the beginning. I'll talk a bit about sort of the data that we've been gathering, and then specifically most of the talk is about infants. Model comparison is also a subject that we undertook, older adults, and then some burden data. So the provenance of our data, that's the first step, of course, in a project like this, is to get good representation of data from different countries in Europe, and we try to achieve that through a variety of studies. And you see we have good coverage across Europe of, I'm trying to point, but that doesn't seem to work. So one of the things that we try to estimate is the cost per case, of course, for treatment. We looked, for instance, by age, but also by other specificities. I'll come back to that in a second. Infants up to 1 year tend to have around 400 euros in the information that we had per case on average for the healthcare payer. So that's what most decision makers are most interested in. For society, it's a bit more, up to 500 euros. For other diseases, we see that usually has a bigger discrepancy, but in the European context, a lot of the productivity days that are lost or leisure days that are lost are accounted for through elaborate systems of maternity and or paternity leave. So that's an issue that we have in Europe, where these societal costs are not that different from the healthcare payer cost, but still there is a difference. And of course, we see a typical age gradient with the highest cost in the youngest children under 1 year, as you can expect, under 2 years, slightly lower in France, in the France study specifically done as part of Rescue. And then when you look at the whole group under 5, the average, of course, decreases. We also had the opportunity to look into the Norwegian data, which gave us a look at the cost per case by 18 months under 1 year. And there you can see, of course, for hospital patients, the higher cost per case in the first few months of life, and the great difference, of course, with primary care costs and outpatient visits. We also looked at older adults, but I'm not going to talk about that at length in this talk. The average cost per infant RSV episode can then be looked at in more detail. We've done that elaborately. One thing I'd like to draw attention to is non-medical attendant cases. They come with very low cost, obviously. Usually that's just medication from the healthcare payer point of view, and from a societal perspective, a lower number of time, a more limited number of length of time taken off to take care of the child. And then we also observe, of course, inter-country differences, as in most of these type of analysis. And we try to interpret and explain that. All this is related to a cohort study. This particular data are from a cohort study for which we have a publication submitted looking at cost and quality of life. This is related to the data that have been collected in the active infant cohorts in the Rescue project. I'm sure most of you have heard about previously in this conference, where there are 5 participating centers in 4 countries, about 1,000 infants followed up, and we had information on 265 RSV episodes in 252 children who were identified through symptoms plus a swab, and we had the opportunity to prospectively collect both cost and quality of life data. And we particularly devised a new methodology a bit. We were challenged by the fact that quality of life measurement in very young children is very difficult. It's a known problem in health economics, and that has been there for a very long time. So what we did was we focused to increase the participation of respondents and make it as easy as possible. We focused on a number of relevant dimensions of the EQ5D5L Euroqual scale. That's the standard scale in Europe for measuring quality of life, actually in the world the most widely used scale. And what we see is that when we look at days since symptom onset on these dimensions, the impact on the quality of life of both the caregiver and what the caregiver rates for the infant peaks at around 3 to 4 days, with particularly sadness or unrest in the child and pain peaking, and at the same time the dimension that we created extra in this study, being worried about one's child. And the standard dimensions for adults, for the caregiver, anxiety and usual activity follow the same pattern, but at a lower level. We were also estimating the symptom duration, which came down to 12.5 days on average for these children. And that gave us the opportunity to try to estimate and quantify the quality of life impact for both the caregiver and the infant. So the caregiver is in blue here and the infant in red. By day since symptom onset, we've been collecting this information every day using, in this graph, the visual analog scale, which is kind of a thermometer scale, with at the top the best health state imaginable and at the bottom the worst health state imaginable. Now, using the typical Eurocall techniques, we were able to calculate that the mean loss in quality adjusted life days per RSV episode for infants was 1.9 and for the caregiver was 0.1. And when we zoom into the infant quality of life, we see the hospitalized, of course, has a higher impact than ambulatory care, and non-medically attended cases do have a health-related quality of life impact that is not that cannot be ignored. It's quite substantial, certainly in comparison to the caregiver impact when we use these standard scales. So that's, I think, a major achievement in the rescue project. Of course, we have a lot of different data sources that we use in different types of analysis, and one analysis that we did was early, I would say at the end of the project, but early in terms of the analysis that we've been trying to do urgently when data came together, was in Norwegian children. And because Norway had a very rich data set that we could use, we used the MC Marcel model that we've applied also to these Gavi countries. We've improved that a little bit. We also added long-term consequences for scenario analysis using data from meta-analysis on wheezing and asthma, and using for monoclonal antibodies the phase 3 data, and for maternal vaccination the WHO preferred product characteristics. So basically in terms of duration, that's 5 months and 3 months. And these are the programs, the different strategies that we looked at. We had year-round maternal immunization and year-round MAP, and then a range of different seasonal MAP programs. As you can see, all kinds of combinations of months within the season are used, as well as a catch-up program here at the bottom, where at the start of the season in October, the children who were born before are caught up with and are also included in the program. I'm going to skip a lot of detail about the input, but let me just, so the main interest here is to look at what is influential and what is important. So what we find is that given a range of willingness to pay values, most countries don't have a fixed willingness to pay threshold, so we have to use ranges in all these analyses. You can see that the seasonal MAP programs are selected based on the premise, and this is of course due to lack of information, that there is price parity. So the price per dose of MAP is equal to the price per dose of maternal immunization in this base case analysis. And we set it at 50 euros per dose based on some of the other vaccines that when they were made available. And so these seasonal programs came out. We also looked at different number of scenarios to look at the impact of, so this is again the base case at the top. We have changed the vaccine efficacy using the Resvax, Novavax data for maternal immunization, extending the MAP duration of protection selects or actually sort of excludes the November-February season to select the October-February season strategy during the season. Sorry, it's easy to get confused here, but to so the season expands, the duration of intervention expands when the MAP duration increases as the preferred strategy. So the colors are showing the optimal strategy. So it is sort of the end result of the cost-utility analysis and is a function of this willingness to pay value. What is really important is the severity of the season. We used in this analysis information from 9 seasons. And when we use the most severe season versus the most mild season, there's a big impact, of course, on what gets selected. If you use the most mild season, no intervention gets selected, so the optimal strategy is to do nothing. While if it's the most severe season and the willingness to pay is lower than 300,000 krone, which is about 30,000 euros, the MAP between October and March is selected. Otherwise, it's the catch-up program when willingness to pay is higher. So there's all these variations. Quality of life loss turned out to be important. Also, if we include wheeze and asthma, that does have a sizable impact on the selection of the preferred strategy. We also did similar analysis in 6 European countries. I'm putting up all these papers because there's a lot of information in those papers, and if you have very specific issues with what we put into it, I encourage you to go to these papers. Some of the papers have very extensive appendices with details about how we went about in informing these models. This multi-country analysis has just come out and is focused on a more limited number of MAP programs, so only October to April with or without catch-up here at the bottom, so only 4 that we compare here. And what we see here is that there is more difference between countries. That depends mostly on the hospitalization incidence. So in the previous analysis for Norway, we used ICD-10 codes. That was what we had. But in this analysis, we were able to use the time series analysis, which was published separately as part of the rescue project by Johannesson and co-authors in the GID 2022. And by using those data, you get a correction on the actual incidence of hospitalizations that has an impact. Now, the Netherlands, from this time series analysis, had the lowest incidence of hospitalizations and had the highest cost for delivery, and that's why it digresses from some of the other countries. So what is important, very much so, has been mentioned already, is the price. This is showing the optimal strategy in different colors. So maternal is black, seasonal MAP is orange, and seasonal MAP plus catch-up is blue. Green is no intervention. And maternal price is horizontal, MAP price is vertical. The larger the size of the square, the more certain we are for the optimal choice of strategy. And what you see is that year-round was never the preferred program, but year-round MAP was never the preferred program. Year-round maternal immunization could become preferred when it is priced at least half of what MAP is priced at. And when the willingness to pay in most European countries is somewhere between 25,000 and 50,000 per QALY gained. So there you go into the direction of maternal vaccine price that's about half or 1/5 of the price of MAP. We also did a model comparison study, mostly to understand the difference between the models that were used until then in the literature on cost effectiveness. We used guidelines on modeling as a sort of a framework to work with. We had 5 models to compare, 3 static models and 2 dynamic models. The 3 models were from industry and 2 were from academics. So what we focused on here is maternal immunization and again monoclonal antibodies. We didn't focus on interventions that were targeted at older children. And an important aspect here I would like to mention as an insight, we learned a lot, the modelers in the different groups from, so we use the same input parameters in these models, and we run all these models and we compare basically the output and try to understand the differences. And so the dynamic models, they have a mechanistic component through which you estimate herd immunity. Yeah, I think that's fairly well known at this stage. But what you see here is the age distribution of the hospitalizations as they were modeled in the bars in age groups, so different stacks, parts of the bars are age groups, and you have the different models horizontally by month. And the orange marker is the input parameter to the models. So what the models were supposed to reproduce. Now, when you use a dynamic model, the model is often calibrated to this type of input parameters. So other parts of the model are optimized in order to fit the observation. While in static models, the inputs that we use are directly fed into the models and come out almost as if, as if they were introduced into the models. And that's why the orange marker is sort of at the same level as where the static models are producing the hospitalizations, but it's at a different level, particularly 2 months before the peak and 1 month after the peak for the dynamic models. Because the dynamic models have to be fitted to these hospitalization data, and through doing that, they make a trade-off between catching the whole distribution and catching the peak distribution. And so what you see is that there's an important point in this season where the dynamic models are less able at exactly reproducing the input. And that has consequences for the impact that they estimate from the interventions. So for static models, I can basically, without going into details, say that they produce similar results. The dynamic models, they, compared to the static models, have a lower proportion of cases averted, but they do show, of course, that's the big advantage, the impact on older age groups. But for infants, that's probably not a huge difference because infants don't tend to mix much with other age groups. Important takeaway is also that the influential parameters in all these models were very similar. So what was influential was very similar. So the efficacy, the quality loss, the duration of protection, season severity, and the cost per dose on the maternal side and on the monoclonal antibody side. Again, the same 5 were most important in all of these models. Just very quickly, something about older adults. I see I have 4 seconds left. So the quality of life, we also had a cohort in Rescue looking at quality of life in older adults. And you can see here pre-season, so no impact yet, but in the RSV group, the impact is in light green, and in dark green is influenza. You can see how RSV tends to have a slightly smaller impact than influenza, but it's quite comparable to a certain degree. And of course, these are very important data also to have to use in cost-effectiveness analysis. So I don't have time to go into that, but we also have a poster here that says that. So my summary is that we produced, we quantified data that will be useful for further analysis as more information becomes available. What we find so far is that maternal vaccination needs to be priced cheaper per dose, to be preferred over seasonal programs in the European context. I'm not going into that. So the influential drivers for RSV cost-effectiveness analysis are, of course, the intervention costs, the efficacy, the duration, the quality loss, but also the probability of hospitalization. And an important lesson is that the ICD-10 codes are an underestimation in the European context that we have to take into account when we try to estimate the impact of these interventions. Seasonal characteristics are also important. And for the quality loss, of course, non-medically attended cases are important. And in what I've shown, it was only taken on board in the 2 dynamic models by Sanofi and the London School of Hygiene. Thank you.
Thank you. Thank you very much, Philippe. That's a very rich suite of analyses that I think will be really important for governments as they're thinking of these interventions. I'm going to hand over now back to my co-chair to do the final panel discussion.
Yes, if we can have Drs. Baral and Dr. Cohen please join Professor Felipe. And then please come up to the mic and ask some questions. I had one for you, Dr. Baral. It was interesting that all the regions, there was no representation from the EMRU region. Can you kind of explain maybe the barriers or the reason for that on your one slide?
For the country-specific analysis. Yeah, I think that is one reason that we don't have, and what we have there is the stock of, but I totally agree with you that there are certain reasons that are still lacking. The picture looks much better than it was a year before, so hopefully we'll have some more in the coming years.
And then the other thing real quickly, the severity, at least a couple of the presentations today mentioned that 50% of the burden is in less than 3 months of age when you look at different populations, but I noticed that you had in your 3-month and older that the severity was, so I was curious why that was so. Like the burden in less than 3 months was kind of the lowest when you looked at severe and less severe, and then it was kind of the higher percentage. I'm not sure.
So I think less than 1 month is the lowest, and then we have the most burden around between 3 and 6 months is based on the data that was fitted, that was available from the literature. So that was the best fit of the data that we had.
Okay, thank you. Oh, sorry. Yes, please. No, you're right. You were first.
No problem. I had a question for Ranju. Thank you. All of the presentations were great. You showed the study that you did in the 131 low and middle income countries, that you applied the same assumptions across all countries. And you also mentioned the UNIVAC model that you're developing or in collaboration with LSHTM, and that's going to be available for low and middle income countries to use. And I was just wondering, when will it be available, and will there be a capacity building program with it where you actually take policymakers in low and middle income countries through the model, explain how they would select the parameters that they want to use and what the assumptions they want to use in their own local context?
Right. So the model, you're talking about the UNIVAC model, yeah. I think Mark can also
I was looking at Mark because then I realised LSHTM. So,
yeah. So that model, that model is like already embedded. So the RSV component is already embedded into the existing model, which has, as I mentioned, I think 6 or 7 other disease, vaccine candidates that are already included in there. We have submitted the paper with the model comparison and with the methodology already, and I think it is going to be, it was almost accepted, and it should be available within the next month, 2 months, I would say. So once that is available, I think as the country put the request and when we know of the interest from the countries, then typically how it works is the developer, Andy, who's Andy from the London School, the team, the technical, with the technical assistance, we form a group within the country, Ministry of Health, and then try to find the local data as much as possible and use all those local data to sort of, sit in a workshop sort of a setting and go over that with, whatever data is available in there and then see the different changes and all that. So that process is sort of built into how we are, going to use that model. It definitely will require some technical assistance, but I think we have experience from Rota, HPV, and all the other vaccines to sort of, build in that too.
Great, thank you.
Please.
Thank you. Thank you for all of the presenters. That was really interesting. I had a very similar question to Aaron for Ranju. Thank you so much for your presentation. I think one of the key issues that we work with as we are working with governments to think through their overall holistic vaccine portfolio, right? So it's not just RSV, it's thinking across what they want to invest in. One of the things that we have, I think, really struggled with is that local cultural sort of uptake of data. And I was curious, I know that the assumption, Ranju, was 66% for acceptance, or I think it ranged from to 94% coverage, excuse me, I'm sorry. But I'm curious, in terms of these workshops, right, once sort of this data is more available and working through the local country context, will they be able to model sort of different levels of coverage? Because one of the key issues that we are facing with regards to, for example, even the HPV vaccine, is really understanding how those assumptions change and what is the economic sort of end game when you think about those different types of assumptions, especially related to coverage. And so I was just curious sort of, how you're going to think about, it's fascinating to me and I'd love to work more. We work with PATH on a number of issues, but thinking through how to have the local decision makers go through the model together, put in these different assumptions, particularly related to coverage, would just be really curious. So I just wanted to hear your take on it.
Yeah, so I think maternal vaccine is going to be particularly tricky because we do not have an evidence around that. Of course, there is TD vaccination experience that we can build upon. Typically for the other vaccines that we have seen is the country have the best knowledge on the, their subnational coverage, and they tend to sort of make adjustment based on, their whatever knowledge is available, and then they bring in insights from the country, and that is the beauty of sort of having that workshop and where they are comfortable with the numbers that they pick in. But definitely as you suggested, it is going to be very tricky for the maternal vaccine in particular, given no previous experience. We've tried to, and therefore we've tried to sort of model for this particular case, because we don't know when women are coming into the ANC, right? The ANC timing is, of course, some of the evidence are being generated, and I think there's a poster out there from Cambry, our colleagues as well, who are trying to understand that and how, just to understand how many women are actually coming into the ANC during that gestation window. Because of the lack of that data, for countries, what we did is we just projected that, because what we know from the DHS for a range of countries is the ANC timing, I think a lot of for the first visit, and then we use that to sort of, and based on the previous FANC or the focused ANC guidelines that WHO had, which has been now replaced by a newer ANC guideline, we use that timing guidelines. So basically when the women are supposed to come for the next, for the subsequent visits, we just use the timing of first visit as a reference and then just model based on the coverage. So, but that is one of the issues that I think the countries will have to, figure out. But they do have the best of the information based on, vaccine hesitancy, how many women are coming, and all those, and to what are the things that are needed to sort of, bring that uptake up as well. So.
Yeah, thank you so much.
Please.
Yeah, I just had a question for the panel about, so I'm an epidemiologist, and when I listen to a lot of the presentations, it sounds like I'm listening to a different language. And I'm wondering how the National Technical Advisory Boards, the guys who make the decisions, whether they're fully aware of the information, or do they understand the concepts that are presented? What's your experience with that? Because I would have difficulty with static and qualies and dynamic models and these estimates and cutoffs. And
You're not the only one.
I would be totally lost if I was on that board. So I just wanted to hear, you know, what the experience you have had with that point.
Yeah, well, I had quite a bit of experience in Australia, in Europe, in different countries. I'm also part of the Belgian NITAG, so that helps also to be a member. Of course, these are really cramped presentations in a 20-minute time slot. Let's be honest. When we discuss these issues at the NITAG level, we take half a day for one of those analyses. That's a major difference, I think, that we have to, you know, at least in my experience, it can take, you know, a very much longer time to explain to people what is important and what the impact is. These are not, for rescue, these are not really final analysis. They're mostly analysis about what is influential rather than final analysis. Of course, during COVID, we also had the opportunity to present directly to government, and that they were also very open to be explain things in depth if they. So the short answer is it takes time. But if you have time, you have the opportunity to explain it properly.
Another thing I think it really highlights is the importance of surveillance and having local data, and that especially before an intervention comes into place. And so with the WHO now focusing also on RSV and other surveillance networks that are in the US and Europe, I think nothing beats having actual data and stories and things like that to let people know. Dr. Cohen, I was interested, like, on even your pilot study, just, it was very intensive. Like, what kind of things do you think that's helpful towards the government to let them know the importance of RSV and implementing it? And when there's, as you said, there's so many other competing
so
interventions.
I think I mean, that was my response. I think in Europe it's a lot about cost, but for us, I think burden and particularly mortality and hospitalizations, you know, that is the driving impetus behind it. Clearly cost is important and has to be presented, but and so in my experience, it's actually a long process of building visibility of the disease, doing the surveillance, publishing the data, saying this is an important pathogen, it has a substantial contribution to mortality, respiratory mortality in children, which we can see around us. And then often one needs to be opportunistic in terms of then the products become available, and hopefully there'll be a moment where the ministry will be open to introduce. But it is a lot of, in our setting, a lot of it is about sensitizing to the burden of disease, the role of the pathogen and the potential impacts of the intervention, particularly in terms of mortality and hospitalizations.
You have a question back there?
Yeah, thank you. This is Amit from GSK. I have a question on the public health impact model that was presented by Pat. It's interesting that the model is static. It's on maternal immunization. The assumption is that maternal immunization will protect infants up to 6 months of age. And when we look at the impacts are shown in terms of under 5 mortality. So I wonder, why did you choose to show it in terms of under 5 and not for under 6 months of age? So infants under 6 months of age.
That's a good point. I picked only one indicator. I think for the deaths averted, I showed it at the under 6 months age as well. But because we were looking at the input data that went into the model covered the entirety of under 5 age, but we could definitely, break it out into 6 months of age as well, very equally.
Okay, thank you.
It's just a matter of picking. Yeah.
Excellent. It's a good reminder that ARI, pneumonia, is the #1 killer of kids, and finding ways to reduce burden and us being advocates for the kids who cannot advocate for themselves, and thinking about other costs that we do at the end of life versus the beginning of life. And so I think it was inspired yesterday by one of our speakers that we need to be advocates for these kids and prevent deaths. And so thank you. We'll end this session. Thank you.
Thank you very much. And thank you also, everyone. It was great to have you participate, and really great questions as well. And thank you for all the speakers. And thank you as well.
Thanks, Mark.
Thank you both. And while Ruth is coming to the stage to announce the winner of the Young Researchers Tournament, I want to, respond to Dr. Cohen that we will try to get this session, health economics session, on day 1 next time. Because it is probably one of the most important parts of the conference, and there is still a lot of audience. Please stay in for the final words. Dr. Ruth, would you? Oh, the certificate. Would you like? You want me to tell jokes now, Ruth? That's probably the best one I've heard today. Leila, how long do we need? I think because people are, after a long conference, I think we need to get started. And we will make sure that we make the pictures with the certificates for everybody on the stage. Ruth, you did so much with the young researchers. Thank you so much.
Oh, my pleasure. So thank you all for staying. This is the moment that actually you've been waiting for during the entire conference, which is to award our young investigators. Is this going forward? Are the slides loaded? I think they're. Oh, no, I don't think that's it. It's interesting. There are all kinds of slides, but nothing I've ever seen before. Roxy probably knows everything about this, but it's great. I will just say I also don't have jokes to tell, but I will just say that we had a huge number, and the slides will tell you exactly how many submissions from young investigators from a large number of countries. There was a panel that reviewed all of these abstract submissions for topic, for clarity of presentation, and as well as for other characteristics. You heard on the first day presentations from our 4 finalists, and you had an opportunity to vote, and I hope that most or many of you did. And we do want to make awards, but for that I need the slides. There we go. All right. The Young Researchers Tournament. So these are the statistics, 41 candidates from 26 countries. These are the characteristics that we scored on, as I mentioned. You heard from Jessica, Sasha, Siripat, and Ashley. And I should just mention that actually this year, which I think is new, Louis, I'm not sure if that's true, but I believe it is, that there are actually cash prizes for these 4 winners, specifically to be applied to their RSV research activities. And these were made with a generous contribution from Bavarian Nordic. And so I'm looking for her, but I'm going to call up Rebecca Glowinski, who was the winner in 2 years ago, when we last, 2 years ago? Yes. And she's actually going to give out the certificates. So, starting with our 4th place winner, Siripat Pasatungo, please come forward. Congratulations. In 3rd place, we have Jessica McClintock. In 2nd place, we have Sasha Speiler. And that means that our winner, our 1st place winner, is Ashley Weaver. So I wanted to actually thank all of the young researchers for coming, for submitting their abstracts. You really are the future of RSV. We're very proud of all of you and very proud of our winners. So one last round of applause. Thank you.
So while we get the presentation of the Brazilian slides now that we just showed accidentally, I want to take this opportunity, so I want to get them back, but I want to take the opportunity, Ruth, to thank you. You have done an amazing job, and we are very grateful. Also on behalf of all the other young people, since I had their age, I have known your work, and you have been at the background of this conference, as all the other RSV conferences that I've ever been to, and thank you for being our mentor today. There is another conference that you all know, the RSV conference organized by iServe, and they asked me to inform you that there has been a site selection and that towards the end of 2024, iServe is going to organize another RSV meeting in Brazil. And I was just informed about it. I think that the selection has just been concluded. If we go to the next slide. Sorry? Oh, I can, yeah, sorry. Yeah. So in Iguazu Falls in Brazil, this is where it is, towards the south of Brazil. The date has not been finalized, so I can't ask you to put this in your agenda yet, but I just want to sensitize you that this is coming by our twin organization that is led by Peter Openshaw, that you saw present our keynote lecture. He couldn't be here towards the end of the meeting, so he asked me to do that on his behalf. There's good transportation over there, so stay tuned, you will hear about iSurf. So, with that, I think it's going to be fantastic. It's going to be fantastic. Yes. So, we just keep on going. There's a lot more. It's, I don't know, make sure you go there. I think we are going there next time too, Leila. Well, this doesn't look good. This would have been the joke that I had needed so I apologize. But so, yeah, this is. Thank you. You can close this presentation now, Leila, and I will now finish this meeting, wrap up. Thank you for staying here until the end. I see a lot of people doing that. I will going to leave the last words to you, Leila. Sorry? From my side, I want to thank everybody who has participated actively during this meeting, the young people, the people who have been there for ages, companies, public health, the health economists that were willing to do the last session. So thank you all. Leila is going to do some very specific thank you to just a few people.
Just some nice photos just to remind you how nice it was.
Yeah, go ahead, Leila.
Okay. So just a short wrap up. So we had 550 plus participants. It's really great and very big. 48 countries. We had 7 fantastic scientific sessions, 2 master classes, and 1 young researchers tournament. We had 185 posters. I was really overwhelmed by all these posters. So thanks a lot, and yeah, it was just great. Yeah, so this was just short reminder. This was day 1. We started with a mother telling her story about the child with RSV. Keynote lecture with Peter Openshaw. We had nice sessions, and also a lot of the posters were visited really good. So that was a good first day. We had a nice inspirational speaker. I'm not sure who was there, but really was an inspirational for how to reach your goals and how to overwin the difficulties. So yeah, so some other nice pictures. Day 2, we had the Barney Graham Awards. Jason McClellan won it, and it was really nice that we could do it online. We will send him the Hawaiian t-shirt. The master classes, so not everybody knows, but we had really 2 successful master classes by Ruth Karen and Rick Robey about how to get published and how about the vaccines development. And this is how we from Resvinet want to invest in the Young Researchers Tournament, the young researchers who are, of course, the future of RSV field. So, yeah. So, did you miss a session, or do you know people who missed it, or do you want to watch it back? It's all possible. So everything has been recorded and live streamed because we always know that there are people who can't be here, sometimes because of visa problems, but sometimes also because of, I don't know, other issues. So we want to have this available for everybody. So this is, you can find it on our website and you can watch it back. I know there were also some people who asked about the slides, if it will be available. Normally we do that, but first we have to ask permission from the presenter. So that's something that we still have to do. So many thanks to our Patient Advisory Board who were here and also raising awareness for both age groups. So the dinner was really great. We had a good party. Your feedback is valuable. Evaluation form, Nina, Roxy, where can it be found? So next week, a post-meeting email will be sent to you, also for accreditation, right? So once again, this was the organizing committee. So Padmini and Paolo already left, so we can't help them. I do want to thank two people in specific. So I want to ask Roxy and Nina to come here. I think both of them, you have had a lot of emails, contact with them. So if you could. So Nina and Roxy, thank you very much. It has, this wasn't possible without your, and I have a bottle of port for you. I think we are there, right? I don't know. Of course, once again, our sponsors, thanks. And indeed, so stay in touch. You just heard about the next iServe meeting, but there will also be a next Resvinet meeting. We haven't yet decided on the date, so we will come back to you. So visit our website and stay in touch. Thank you very much.
Thank you.
So